closed session and recess, and now is back in open session. And the next item on the agenda is item 12, which is optimal team practice. So two parts here. The first one is for an independent physician assistant board. So the last meeting, we appointed a subcommittee to look at an independent physician assistant board. And I was given the authority to appoint two people to do that. And so Xavier Martinez was appointed as a board member, and Bob Miller was the other person appointed to that subcommittee. I don't know if do you want to just say hello, Bob? Is that okay?
I'll be up there in just a moment.
Okay, all right. And so we had looked at becoming an independent physician assistant board, and then we got the initial language on SB 697, which did a lot of that already. And so the committee basically decided to hold their work until SB 697 sort of went forward, because we didn't want to duplicate work. Just to reiterate, the move to be an independent board is not a move for independent practice for PAs. It's just for the board to become independent, which is in our strategic plan. Sorry, strategic was a hard word for me there. Is part of our strategic plan, and we may move forward with that more at another time. But just wanted to update everyone as to those appointments and the fact that we have a subcommittee for that, which will likely be giving reports in the future. And that the reason we don't have a report now is because of SB 697. So any comments or concerns on that? Great. So we can, sorry, Bob.
Bob Miller from Kappa. I'm a past president, current treasurer, and I chair the professional practice committee. Just to clarify that there's been several versions of this bill over the weeks and months, and initially that was in there about separating the boards, but current legislation that's not included.
Right. Okay. Very good. Thank you. Further discussion? Okay. Yes, sir.
Why was that changed? The current legislation taking out the independent board?
With some of the difficulties we were having with the other language, we felt that it would be better to use that as a second step. In other words, to try to get the bill passed first, and then subsequently, perhaps the next year, go to the autonomous board.
Okay.
We didn't want to, with the difficulties we were having with language, we didn't want further difficulties to make the bill harder to pass.
The committee can work.
Okay.
Once you pass it the first time, the second time around, can we interject those things that we want? And do we have to get a second passage, or how does that work?
I think we'd certainly be open to that, but I don't know if we could add that big of an item in late in the game. But that's, we're here to listen to your comments and your concerns, and bring them back to the board, and do what we can to work with you to try to get the modifications made.
So go ahead, Xavier.
I just have a question for you. Can we comment on this now, or are you going to do something first, and then we can come back and comment on 697?
Well, then we'll move on to 697, but right now we're still talking about the committee to become an independent board. Okay. And so the committee can work with the authors of 697 if they want to put that back into it, and if not, the committee can work separately on separate legislation for that. So the board has given your subcommittee authority to investigate that and come back and report to us on what a good course of action would be and how we should go forward, whether that's as a amendments to the bill as currently written, or a separate bill maybe next year.
Okay.
That's kind of what your committee is all about.
Thank you.
Sure. And
I think the Kappa board would be happy to help support that, given the right strategy and when we want to put it.
Right, the timing is important. So, okay. Further discussion on that topic? Public comment? Okay, great. Thank you. So moving on to SB 697. So this is Kappa's big bill, authored by Senator Caballero. Did I say that right? I had to get the "ay" in there from my high school Spanish. So first, just want to thank her for authoring this bill. I think it's great. It's important. I know she's taken on some really big bills this year, and appreciate her looking out for PAs and that sort of thing. So I appreciate her being willing to help Kappa with that, and PAs in general to have a Better Practice Act. So we've got a copy of the current most recent revision, which all of the board members should have. It's the red and blue document in front of you. Should be dated 4/24. So I have a few concerns. I'm happy to open it up for discussion. I don't know if anybody wants to bring anything forward. Looks like you're all thinking a little bit, so I'll just bring my things forward, the concerns I have with it forward so that we can maybe talk about it. So one of the first thing we're a little bit concerned about is that it defines as people who can talk about or sign a practice agreement as an organized healthcare system, and that is at the bottom of the first page, J. So it would be Section 2, 3501 in the new numbering, J and K. And my concern here is that other people like administrators or office staff can be signing a practice agreement. And the language does say that it has to include a physician and a PA, but having an administrator signing this agreement puts them in a sort of supervisory position, which concerns me and may not be legal. So I don't know if you want to comment on the legality of that, but I certainly would not want a office manager telling me how I can practice.
So just to follow up on your question. So in California, it's illegal for artificial entities or unlicensed persons to practice medicine. Artificial entities are not allowed to have any powers, rights, or privileges with respect to provision of medical care and decision making. And so with respect to item 3501 sub K in section 2 of the bill, it says the practice agreement, which currently is defined as between a physician and a PA, includes, if applicable, administrators of an organized healthcare system that outlines the medical services the physician assistant is authorized to perform and that grants approval for physicians and surgeons on the staff of an organized healthcare system to supervise one or more physician assistants in the organized healthcare system. So when I look at that, in my opinion, that's conferring upon an artificial entity who's defined in sub K to include clinics, outpatient settings, health facilities, county medical facilities, accountable care organizations, home health agencies, a physician's office. I'm not sure I understand that, but medical corporations wouldn't be an issue because those have to be staffed solely of healthcare providers, but it's the administrator part that's troubling because, again, it's unclear if that person's a healthcare provider. So my concern is that we're allowing what would be potentially considered the corporate practice of medicine in allowing these organizations to have a say in what physician assistants can perform in terms of medical services. The other issue with the last part of the sentence that says, and that grants approval for physicians and surgeons on the staff to supervise one or more physicians. So again, they're controlling supervision, they're controlling, they would be by extension controlling medical care. So those are the concerns when it comes to corporate practice of medicine. Any questions from the board members on that? The other thing, 3502.3 is related to that corporate practice issue. 3502.3 also talks about what the content of a practice agreement would include. And again, it refers to the organized healthcare system, determining what additional provisions would be in a practice agreement. It also authorizes the organized healthcare system to approve the practice agreement, quote unquote, on behalf of the staff of the physicians on the staff who would be presumably supervising the physician assistant. So my other concern is, how would those physicians know they're responsible for supervision, and how would we enforce that when the organized healthcare system's deciding who's supervising? So those issues altogether.
Yeah, the other concern I had about that is if the person signing the practice agreement is in a different specialty than the PA is practicing in, how can they really say that they're okay to do that, right? And there's nothing in here that says that they couldn't be in a completely different specialty, because I don't know what a neurosurgical PA's scope is. But according to this, family practice doc could sign off on the scope of a neurosurgical PA, which to me seems a little concerning. So that's the first concern. Any public comment on that? Okay.
So the vision of the practice agreement, I get where you're headed, I do. But when we met with the California Medical Association, we had many discussions about this, and their lawyer was in the room. And so it's this umbrella. So the practice agreement is literally with the practice. So a medical director, a physician would determine that there are specialists within there. There's an orthopedist, there's a multi-specialty clinic. So they are the administrator, by the way, is not directing. It would be a physician, at least one PA and one physician, and if applicable. So there's that whole thing. But it's not directing. I'm not explaining it well. Bob, help me with this practice agreement. It's an umbrella with the entire practice. So within that multi-specialty practice, there is an orthopedist, there is a family practice doc, and they are going to be supervised by those specialties. But there's one practice agreement that says within these four walls, you will be supervised appropriately. You've all been credentialed. You've all been known to have the competence that you should have. And I'm, on behalf of the practice, going to sign it. There's not this one-on-one relationship with an umbilical cord from one physician to one PA.
Who writes this global agreement? Is it from the hospital? Is it from the state? Is it from CAPA? Is it from us?
We would have an example for the practices. Many already have this. This is already existing in many, many places. It's just a practice agreement. But in addition, because you're a PA, you also have to have a DSA. So there's already this document that kind of talks about what everybody does within the practice, and everybody's credentialed. But now, because you're a PA, you get to go back and have a DSA as well.
So we have a DSA and this new agreement.
Well, no. I'm saying currently, right now, in
Right.
many practices, there is this global document. It's been through credentialing. It's been through all of this. So this global agreement exists. I don't know what it's called. It could be called any number of things within a practice right now. But right now, because you're a PA, you, different than the NPs or other people in the practice, have to have this DSA that makes you tied to one physician. So the practice agreement was meant, and we're listening to all of your concerns, it was meant to be more global and be an umbrella document.
I think you're conflating credentialing with a practice agreement, or DSA as the old language is, and they're different, right? So the credentialing privileges are granted by a credentialing committee at an organization or hospital or whatever that says, in our facility, these people can do these things. But we don't really cover that under our regulations. That's not enforceable for us. What is enforceable is the practice agreement, and there's no really bounds on this practice agreement saying who can do what where. And I get that you want that sort of determined at the practice level, and I think that's great, but you also have to have some reasonable framework to do that within, because there's always going to be somebody who will come up with a wonky idea, and there's nothing to limit them from doing that under the way this is written. For example, if you don't have objective criteria, some of the language that is in the bill talks about what available, like the supervising physician must be available. Well, there's no definition of what available means other than it clearly states in several places it doesn't require personal presence. But what is available? Is it, well, I can get a hold of them in 2 weeks?
Should we just make it within electronic communication? Would
Well,
that
I don't-
define available?
I'm not trying to tell you how to write it. I'm just saying it's.
If we did that, would that, because that's what it is now, could we, and we're gonna, I hope, be able to work with you outside of this meeting and really maybe have one of you, have this board assign one of you to sit with us and work with us on all of this, because you've brought up really good points. So I hope we can do that and try to find some amendments. But in that case, right now it says within electronic communication, we could put that back in.
Currently, in that position that you're discussing, it's covered already in 1399-545, so supervision required. A supervising physician shall be available in person by electronic communication at all times when the physician assistant is caring for the patient. So we could use your words already.
Yeah, but have you struck the regulation that, the law that goes with that regulation?
Not yet.
That's my concern, is that many of the laws that were struck in this bill invalidate regulations, right? And so then we're left with nothing. That's the concern.
And we're hearing you and we're listening, and we want to work with you in the next 2 to 3 weeks and come up with compromise language, because what you're telling us is really good stuff, and we appreciate it.
Okay,
So I just want to make sure that we don't confuse the two issues, though. The first primary issue is the fact that the collaborative practice agreement, or the practice agreement, includes an organized healthcare system, and that's where the unlicensed or corporate practice of medicine issue comes in, because it says that they decide the medical services the physician assistant is authorized to perform.
Within those 4 walls.
Right, but they should not be involved in that from a legal perspective. In California, it violates public policy for the corporate practice of medicine, because you're allowing people who we don't know if they're medical professionals or not, because it doesn't say that in here, that the system decides what medical services are performable. And under California law, there's 2 reasons why corporate practice of medicine is illegal. One is we don't want people who are not licensed to practice medicine determining medical care for patients in California. The second is the corporate exploitation of medicine
Oh, no
in California.
question. And when we
So-
met with the CMA, this was they too do not want a non-physician determining this. They knew
Right,
that too.
so-
It says at least one physician and at least one physician assistant. That's the baseline. And if applicable,
Right, but that's the part that's objectionable, because then we leave it up to private parties to determine if it's applicable.
but you still always have a physician and a PA.
Right, but they cannot, I guess I don't know, maybe I'm not explaining it correctly, but it's the fact that you're authorizing a non-medical entity to be a part of that decision-making process. That's
I see what
problematic
you're
from a
saying.
perspective.
So you're suggesting that we just strike that?
Getting rid of and if applicable.
I don't know why we would amend the current definition for the delegation of services agreement. It's really an agreement between physicians and one or more physician assistants. So those are the people that should be in the relationship, because the delegation, we're still talking about a supervision model. So the person that's supervising decides what's delegated, not some other entities that they may work for. I mean, entities can employ healthcare professionals, but they can't control their medical judgment and professional opinions. So that's why there shouldn't be anyone else, in my opinion, on the agreement between the physician and the physician assistant.
So I am hoping, and I certainly think Bob and I have discussed that as well. Again, if we can get a representative from the board to work with us in the next 2 to 3 weeks, that's certainly another thing that we can look at.
okay.
Can I comment for, here's, I think we're talking about the same thing. Here's the whole, I'm sorry. Sorry about that. Here's a glaring hole I see in this. When you list the qualified organized healthcare systems, you include a home health agency, which requires no physician whatsoever. All that agency does is direct skilled nursing to a home. And now we're putting them in a position of defining the practice agreement. I mean, is that? Yeah, and believe me, I've had experience with some home health agencies. They can be a nightmarish collection of rogues out there, and to put them in charge of administering a medical practice would scare me significantly.
Again, these are all good comments that we hope to take back and
Yeah.
redo version 23 of this bill. But we're really appreciative of your feedback.
Okay, great.
And our intent is always to have the physician involved.
Always.
Oh, I understand that, but as we know,
If the words on the page don't reflect it, then what's the
yes,
point?
it's a problem.
We want the words on the
Can I-
page to.
Because
Can I
I
just-
could easily see a home health agency reading this, and if they're sharp enough, saying, wow, we get to
Yeah.
now employ PAs as we see fit.
Can I just take a step back, because I know that we're reading a lot into this, and as PAs, it's really striking to see some of these things. Can we just take a step back and see what was the original intent of this bill? Because maybe that would help us, and I know there's been 23 revisions, and maybe this is the reason why we're having so much angst with this right now. Can you just take it back a step and just bring us up to, from where it started, or what was the, proposed, what was
The
it supposed to
optimal
do?
team practice part?
Some of the basic concepts, I can give you four, that kind of the pillars of what we've been working with. One is a commitment to team practice.
Right,
Team practice works for PAs.
Yes.
We don't want independent practice. That's very clear. We want to work with physicians. We want the team practice relationship to be determined at the practice level, so that the practice level, the physician and PA team determine what that PA can do within their defined scope.
right,
Number three is the autonomous PA board, and that's something we've already discussed. And the fourth is direct reimbursement. We want to be able to find a way to have direct reimbursement for PAs, both in the public and private sector insurers, to reflect their productivity, not only in the practice, but in the healthcare arena. Because right now, we're invisible to some extent.
right. So with that, I noticed that even just what you said, OTP is not on this form. So is that strike through? Now it's just practice agreement supervision, or OTP is nowhere in this? So I took it as this, we're not moving towards OTP. This is something different than what we designed.
Moving toward is the key word there, but this is not optimal team practice. We went through many, many meetings with many. The physicians feel that optimal team practice in its purest form is, in fact, independent practice. We disagree, but at this point, there was a lot of discussion and a lot of meetings. So we did what we did to keep the bill alive, and now we will work with all of you to continue to keep the bill alive and make the amendments that we can make to make this board happy as well. But each time we do this, it dilutes the pure OTP. We wanted parity with nurse practitioners. That was what we asked for, parity. So this practice agreement was, in theory, what was going to offer parity. You know, nurse practitioners don't have this one-on-one. They have a standardized procedure that sits on a shelf somewhere, and so we were seeking parity with nurse practitioners, and the practice agreement was the ticket to that parity. So.
Well, this is still a fluid document, and we welcome input so that we can make it better. But there are certain words like supervision that we may not be able to get through to collaborate, or what's more consistent with OTP. We just may not get there yet. We knew starting out that we're maybe in the first year we're not going to get all of OTP at one time. So we're working with the stakeholders to try to find out where everybody is, what language will work, what language doesn't work, and that's why we're here today.
Can you tell me what was the disagreement from the medical association, or?
You take the word supervision away, and in their mind, that's independent practice. By that's it. That was like it. So we said, what if we use collaborate? What if we have a euphemism for supervision?
Or oversee their medical practices. And we've tried several different words to try to make it work, and we're still working on it.
Sorry, Xavier, go ahead.
Yeah, I have a question. I mean, this is the third amendment that we just got recently received, but I guess my basic question is, why don't you approach the board long ago when this whole process was starting to see to get the input, at least from the executive director, and the president and vice president. So
I was here at the last meeting. We did talk OTP. Jed and Bob did a presentation on OTP, but what happened was we all kind of agreed that OTP, I feel, was the way to go. We introduced a bill on all those concepts that we had talked about, and then it kind of very quickly, and you saw the dates of those amendments. So we haven't been here to discuss this with you, but we are here today to discuss it with you, and I hope that we'll be able to talk more about
well,
it.
didn't the person who carried the bill ask that question as to why the board was not brought in?
No. No, she did not.
See, I have a real problem with that.
I agree.
We're stakeholders. We were totally ignored. You went to everybody else. You even went to the director of the Department of Consumer Affairs, who's no longer here. And we were never consulted on any of the language in this bill. It was a secret. And then all of a sudden, February 22nd, it was introduced, dumped in our lap, love it. And then, 2 weeks later, it's amended, and now it's amended again. And now it's, we want your input. We want to know what we need to change.
I have to agree with you, and my apologies. Bob and I talked about that last night.
Can you move the microphone closer? They
So
can
we
hear
do
you?
hope, though, and I'm with you, Bob. I apologize how this worked out. This has been a very difficult bill that we've never seen happen like this before, and we've both been around a long time, Bob. And we've usually worked with the PAB very differently, and we didn't this time.
I'm curious why you've struck so much language from the current law. There's a lot of red on here. And particularly in relation to prescribing, there's a lot struck that is working. So what was the intent behind that, and what are you trying to accomplish with a lot of the prescribing changes? Because from my opinion reading this, it sort of went from good, which is what we have now, to worse. So I'm not sure exactly how that happened and why it ended that way.
I think some of it is, they pulled from the nurse practitioner, we were asking for parity. So some of this is direct language from nurse practitioners. It's how they do things currently. Sorry. It's how they do things currently. So a lot of that nurse practitioner stuff was stuck in here.
That's what I'm asking is why. Like,
To-
ours wasn't really
Exactly.
broken.
To try and seek this parity and have things done like it's done with nurses or nurse practitioners. So I believe that was much of it.
Did you do any work to sort of determine whether or not that was necessary? Like,
Oh, the amount of hours, yes, we did.
because I don't know that it is, in terms of prescribing now, I don't feel like it's broken. And I feel like there's some additional burdens put on the prescriber in this bill, which would require the practice agreement to list all of the times that a PA could give a Schedule II drug. And then each practice agreement would say that, which would mean that has to be sent to pharmacists. How is a pharmacist going to know what a PA can prescribe, which is not currently how it's done. It's much simpler. So,
And we never felt that each pharmacist would have to have a practice agreement. I mean, obviously, if that was the case, then that would be unwieldy and unnecessary.
well, how else would a pharmacist know?
But how does a pharmacist know now that you can
Because the
prescribe
way
a
the law that
Schedule
you
II?
struck out, the way it is written now, we are allowed to do that if we've had the controlled substances course. But in the way you've written this law, it has to be in the practice agreement, and that the pharmacist has no way of knowing, so we would have to make the practice agreement available to the pharmacist, which is very problematic. And so I'm just trying. I'm not trying
Your
to.
DSA right now it delegates to you whether you can write 2, 3, 4, 5 in your DSA. That's delegated. How does the pharmacist know that was delegated to you today?
Well, now you've got it in the language that if the pharmacist is in doubt, we have to furnish them a copy of the practice agreement.
That's standard pharmacy language. That's what the language is in the NP bill. That's.
We've never done it before.
It's not in the law now, and we don't have any problem with it. So you've added an additional requirement that is burdensome and problematic. The controlled substances course needing to be every 2 years.
I can't find that, Jed.
I have it
It
right
says
here.
that.
It says it has to be a continuing education requirement. It doesn't say how often, but then we'd have to do a regulation to specify how often. So I don't know how it would be harder to implement right away because we wouldn't know how often we could mandate that course. It could be every 6 years, it could be every 8, I don't know, but it would have to be done by regulation because the
But-
way it's currently drafted just says continuing education
But
requirement.
we have to do continuing education every 2 years.
That's
Right, so that's one interpretation, that it be done every renewal cycle,
Right.
right?
Can you tell me where that is, Jed?
give me a second, please.
So we're looking at section 4,
Page 4 and 5.
Business and Professions Code, section 3502.1 F3.
Yes.
So it says continuing education. It doesn't say how often the continuing education requirement needs to be completed. So there's a little ambiguity there and so that usually to me is a signal that we'll have to do regulations to mandate how often that continuing education requirement is, if we mean anything less than 2 years or more than 2 years.
Well, it's just from reading it without attorney vision.
Yeah.
Knowing that I have to do continuing education every 2 years, anything that is required would have to be repeated every 2 years. I have a 50-hour requirement every 2 years to keep my certification and license. So that's the way I read that. If I'm reading it incorrectly, I apologize for that, but that's the way I took it.
Yeah, so it says PAs who hold an active license who are authorized through a practice agreement to furnish Schedule II controlled substances shall complete as part of their continuing education requirements a course including Schedule II controlled substances and the risks of addiction associated with their use. So
I'm wondering if that's part of that 1109. Do you remember AB 11? Was it AB or SB 1109?
the only thing they added was the risks of addiction associated with their use. That's what was added. It wasn't added as a continuing education requirement. Right now, it's a one-time course.
Okay. Good feedback again. Thank you.
And if other members have concern they want to discuss or just want to talk about it, but one thing that sort of bothered me is that this has to specify how services are performed, the practice agreement, instead of what services, but how they're performed, which is really problematic. I brought my non-marked version here, so it's taking a second to find it. Do you have the location?
Yeah, that would be Section 5 of the bill that sets forth the requirements for the practice agreement. It says authorized to perform and how the services are performed. So right now, it's not a legal requirement that the physician and physician assistant document how each service that's being delegated is performed, only what they're authorized to perform. So the how makes me wonder how much detail would have to be in the practice agreement. And that would be difficult to implement for the board, I think, but probably even for the practitioners to know what to put in there. I know that staff indicate they get questions all the time on what should the delegation of service agreement look like, and we have a sample online for people, but it doesn't include how the services are performed. It might look like they're trying to control the judgment and discretion of the PA by putting how the services are performed in there.
No, I think we need to look at that and make whatever modifications we need to clarify it.
What are your thoughts on, or other members of the board, on having physicians that are in a different specialty than the PA making a practice agreement?
Absolutely not.
So that is not in the current law. There's nothing that would prevent that in the bill. And that's one of the things that really concerns me from a public protection aspect, is that PAs are trained as generalists, right? We train in every specialty. And then when we go to work in a specialty, we perform tasks and duties that are much more advanced in that specialty, determined at the practice level. But right now, the authority to perform those more advanced things is defined and limited by the physician that is
Right.
doing that, being in the same specialty. I don't see anywhere in here that says that. Is that something that you've given consideration to, or?
I've noted that already, that we have to work on that language.
Okay.
But again, in our minds, when it was optimal team practice and we were using this umbrella model, that there is a medical director who is there to ensure that everybody in the building is doing their job and performing to the top of their license, that the director would ensure, the medical director would ensure that a brain surgeon or a PA in family practice wasn't doing brain surgery. That's just part of the whole running of the clinic or the practice. It was standard of care. We were hoping that you guys would regulate all of this on standard of care like the physicians do. It is not, it's standard of care is that if you're a family practice PA, you're not doing brain surgery.
But physicians have the benefit of a residency, and they only practice in the specialty for which they trained in residency. They're not generalists like we are, and they can't practice in different specialties at the same time. And they don't have delegated authority like we do, which this does not do away with. This is still essentially delegated authority. It's very similar to that.
It is very similar. So
So-
that was the theory, is that you would all just now regulate on standard of care. But I understand what you're saying is that it's very different. We wanted this to be regulated like the medical board regulates a physician. You don't do that, which is outside your scope of practice. You just don't do it. And if you do it, you guys would bring them up on regulatory charges, and they would be in trouble if they went outside their scope, their individual competencies. This bill says you don't do anything that you're not capable, competent, and trained to do. So you would regulate with standard of care. But I get what you're saying, and we're certainly going to look back at that.
I just want to add just a few things in terms of, I know OTP, the wording, we're trying to move away and trying to redesign some things. I would caution, don't throw the baby out with the bathwater. And as a person who is at the ground level as a clinical associate professor at one of the local medical schools, I just want to make sure that we are understanding that the new school of medicine is different from what the old school of medicine was, in the sense of the new medical providers that we're putting out currently do not want to supervise. And that could be a global, but that is from my own opinion. They do not want to supervise somebody. So when they go and do their job, they want to just do their job and go home. And the medical model that we're in right now precludes, I think, PAs from maximizing and going forth in the next generation, meaning that we have another provider who is autonomous, somewhat. And so even though verbally the medical association is saying we want to supervise, the new school that we are putting out of clinicians and physicians do not. So there's a mismatch in terms of what they want to do and what's actually happening. And so in my own area, when we've gone from dominance of PAs, we've now counterproductive. We are not the dominant medical provider there at that institution. So
Because you have to be supervised.
because we have to be supervised, correct. And so I understand what we're doing, but don't throw the baby out with the bathwater. And I think we're just going to have to dig deep and fight harder, because we are going to be out of a sustaining profession, I think, in several years to come if we don't really redesign and look at this.
Are they
Very well
replacing
put.
us with NPs?
Yeah.
Yes.
Okay.
Thanks, Sonia.
So I think the question is, how do you set just some boundaries, right? Some left-right limits to what is possible for this. And I think what's important from a regulatory perspective for us is, we're not interested in the 99% of people that practice ethically and do the right thing. Like, we know they're going to do the right thing. We're interested in the 1% who are going to be squirrely and do something crazy. And we need the ability to objectively say, this is clearly wrong, you're clearly outside these bounds, and therefore we can restrict your practice. And we would like to do that before they hurt somebody, right? Not after. So I think that's where this is coming from in terms of just looking at this from an enforcement perspective. But I totally agree. I mean, clearly the way the wording is now is problematic.
It is.
Because there's burden without reward, right? In terms of the way the relationship works. I thought the initial language of the bill was pretty good, just needed a few little things. I was disappointed in this language because there are a lot of strikeouts that I just don't understand why a lot of these things were struck. Because they have the effect of canceling out regulations, right? And so I don't know, was that a careful, thoughtful process?
I promise you, it doesn't seem like it, but everything was a careful, thought-out process. I just feel like we're too many cooks in the kitchen and too many masters to listen to, and you guys are certainly being listened to now. And Bob, my forever apologies that this wasn't done sooner. That just is unacceptable. So we hope that you will forgive us and let us move forward and really look at this, and offline just look at it, come back to you in a very speedy time frame and explain this more clearly.
Okay. Anyone else have any comments?
Yeah, I think we talked about 3502.3D, or wait a minute, I'm sorry, C, the methods for continuing evaluation of competency qualifications of the physician assistant. That's a wide open sentence.
Well, I look back at our regulations, and perhaps we could just use your own words out of current regulations. A physician assistant, this is 1399-540. A physician assistant may only provide those medical services which he or she is competent to perform and which are consistent with the physician assistant's education, training, and experience.
And patient health care.
And patient health care.
Boy, look at you.
Okay, so this is, do you have a
I
question?
have some other issues that I want to kind of make sure that the public members as well are aware of. So one of the things was supervision shall not be construed to require the physical presence of the physician and surgeon. So the question is, under any circumstance, because if you have language like that in a statute, there'll never be a situation, even on probation, where you could require the physical presence of the physician. So that's where that language we just discussed comes into play. There may be situations where you do want the physician on site. So the difference between the physical presence it's kind of ambiguous to me what that means, but the way that your board is interpreted in person is to be on the same site in the facility as the physician assistant. So there may be situations where just having them on site is more practical than telephone or electronic communication. Right now, those are options for practice, and it is dependent upon patient care and the patient condition. But if you put a statement that's affirmative, that they never can be construed to require physical presence, that kind of undercuts this board's ability to set those kinds of standards in certain situations. And I would recommend putting against putting a definitive statement like that, unless you can say that in all situations, even when they're on probation, it's not appropriate to have the physical presence of the physician. So that's one public protection issue that I want to bring forward. There's also several places in the bill where they strike your ability to adopt regulations to establish medical services that are performable. I think you should retain that authority because there may be common medical services that all PAs can perform. You have a regulation that sets forth those medical services. That would go away if this bill went into effect. And also, the ability to set minimum standards for supervision and regulation. You still have authority to do that. You could make those changes today in regulation, with the exception of the podiatrist requirement. When you're working with a podiatrist, the supervising physician has to be physically present and physically available. So
was the intent there that that doesn't need to be in legislation because it's determined at the practice level? Is that
The personal
Correct.
presence doesn't need to be in legislation?
no the
supervision
the-
or medical services performable.
correct?
Those are in regs. Medical services.
Right, but when you strike the
But you struck it.
legislation, then the reg doesn't count anymore.
Well, you struck the authority to adopt regulations for that purpose in
And medical
3502.
services performable would go away?
Our regulation would be superseded by this, in my view, because you've struck the authority for the board to adopt regulations that define the medical services and also the supervision. There's a section that says, okay, so 3502A talks about the authority to adopt regulations to establish medical services that are performable. That was struck. But interestingly enough, in another part of the bill, it refers to that section having a regulation authority in it, but it's not there anymore because it was struck.
So if,
So-
let's pretend like this bill got signed and went into effect January 1 of 2020. Would medical services performable be there on January 1?
I think it would be hard for us to argue that we still had the authority for it because you struck the underlying statute that authorized us to do regulations to set that criteria forward. And essentially what we would have would be that the doctors would figure out what medical services the PAs can perform and what level of supervision they should be providing. And there's another part in the bill where the supervision is determined by the physician. The manner and extent of supervision when it comes to controlled substances prescribing is set by the physician. So what if they did substandard supervision? They could say in their own agreement, I complied with my agreement, so I met my supervision requirements. So you should allow in my opinion, this board and the medical board to set the standards for their licensee populations when it comes to supervision, and they should be able to retain that authority so that the minimum standards are set by this board and not by as you mentioned, those practitioners that are not meeting minimum standards. It's harder to regulate by decision, like you mentioned, by going in cases and prosecuting, on getting experts on a case-by-case basis. It's much easier if this board agrees that there's just minimum things that should be done in every case, do it by reg, and then when people call up and ask what's the minimum criteria, we can point to it. It's much easier to enforce and implement that way than on a case-by-case basis.
Just the very minimum. Just a left-right boundary.
Right.
It doesn't say that they can't do more, but at the very minimum, this is what supervision means.
Right.
These are the medical services that a PA can do
Right.
generally, and you can add to that, but generally you have to be able to do these things. And that is that's why I asked you, why did you strike out a lot of these things, is because when the law authorizing the regulation goes away, then the regulation goes away.
Yeah, the unintended consequences would be disastrous, and I
Right.
will apologize to all of you for the rest of my career. I am so sorry, and I hope that we can just move forward. I really apologize. This is not how we operate.
So there's a
Keep
few
going.
other things.
Keep going.
So those two provisions I was talking about, Section 2, 3502A, and Section 3, Section 3502C3. Those are the two reg sections that are struck from our current authority in the bill. Then record keeping. So one of the requirements is that for each medical record, for each episode of care for a patient, it identifies in the medical record the physician and surgeon responsible for the supervision of the physician assistant. It's struck in two places, 3502A1 in Section 3 and 3502.1E2. Just from a consumer protection perspective, I think the idea is the consumer has the right to know who's responsible for their medical care in every situation, instead of having to ask, and I wouldn't know, I mean, I consider myself an educated consumer, but before I started to work with you at this board, I didn't even know the delegation of services agreement existed. That would be the only way that I would know, if this requirement was struck, who is responsible for my medical care.
Which
So-
I think that goes back to having a subset of duties outlined in the practice agreement that the PA is responsible for, right? And so, to me, it's not clear, is there a subset of duties that the PA is responsible for that the physician is not responsible for? Or, which makes sense, that's how we operate. Or is the physician responsible for everything we do regardless of what we do? And I don't think that's well defined here. And I'm not sure kind of where that's going.
So under current law, because they're a supervisor, they are responsible for everything the physician assistant performs. And so that's why the medical record should reflect that. That's what.
No, I'm
the
not
issue
just,
is.
I know what the
Theory.
current law says, but
It was that they are responsible to ensure that you are practicing within the standard of care, that they have ensured that you know what you're doing, that you're providing good patient care. That is what they're responsible for. They're not responsible for the acts. They're responsible to ensure that you provide good care within their four walls.
So under current
Sharing.
law, 3501B says they are the agent of the physician assistant acts as the agent of the supervising physician. Again, that's a consumer protection issue and the foundation of a couple of our regulations. So my concern would be that the authority for those regulations would be affected, as well as add a sense of not being clear about the responsibility with respect to the physician and the physician assistant for the patient.
so this goes back to what I was just saying. Like, is there a subset of duties? And what the reason I'm asking this is in your conversations with other stakeholders, was your idea to set aside a subset of duties that the PA can perform without the physician having responsibility for that? Or is the physician responsible for everything that the PA does? Meaning that the physician has sort of a general responsibility of general competence of the PA, but that the PA is responsible for those standard duties. If then does that absolve that? Because this goes back to the original reason for the legislation, right? Which is that the physicians are not wanting to have to accept responsibility for things that they have said that we can do. They are, when we talk to them or we need help with things, then they should be on the hook for it. But there are some things that we can do very well, right? And so was the intent to do that, and that's why this was struck, and then it just kind of got
Agency
orphaned,
was
or?
struck. We struck agency. You are no longer an agent of your supervising physician in this new bill. You have your own practice act. You are a professional. You are not an agent. You are a PA.
But then in other parts of the bill, it says the physician is responsible for everything that we do. So
Right.
then
Therein
when you
lies the rub.
right, so if you're going to say the physician is responsible for everything we do, then we need this language to stay in
Right.
there.
No,
If-
I get it.
You
and
can't have
was-
it both ways. I think
You
that's what I'm
cannot.
saying.
You can have it both ways. And again, it was responsible to ensure that the care that was being provided was standard of care. And that in those four walls, that the physician, and only the physician, not the administrator, but I get that the language doesn't say that.
Yeah.
But that the physician within those four walls is responsible to ensure that the PAs are performing excellent medical care. Not that they're responsible for every act, they're responsible for ensuring that things are gonna go well.
They're meeting the standard of care.
Yes. And that you're now a PA, you're not an agent, you have your own standard of care, and you will perform within that standard of care because you're this professional PA who will do that.
So it kind of goes back to the same thing. If you're going to leave that statement in there that they're responsible for everything, then we still need this language in our laws. If we're going to do what you just said, then there needs to be language that says that if we're gonna strike.
Yeah,
The-
and get rid of supervision if
Yeah.
we're gonna do that. No, I
But
crystal
in
clear.
1399, 541, I mean, you were there when we fought to get this put in,
It-
because physician assistant practice is directed by a supervising physician, and the physician assistant acts as an agent of the physician. Hospitals love that. And nurses love it, because if we give them an order, they have an out because we're the agent of the physician. We take that away,
Yeah.
we're hurting ourselves.
And that was discussed. It was discussed that we've lived and breathed on Agent Michael Scarano. And I mean, that's just,
Yeah.
that was not forgotten. But what was discussed is that you are now your own person with scope of practice in medical services performable, and you will be able to move forward with that. But now,
Yeah, and you're responsible for yourself and your actions under the umbrella authority of this practice
practice
setting with a physician.
Did you guys talk to hospital associations at all?
Kat Scott, our former lobbyist, is the lobbyist for CHA. So we did. Obviously, we didn't do as much as we needed to do.
You're still running this as a one-year bill?
Yes, we are.
Okay.
We are.
You wanna,
I'm still working through it. Is that
Go on,
okay?
Christy, come on.
Is it okay for the board members if I keep vetting this stuff out? Okay. So, the cap. So the current statutory cap is a 4-to-1 ratio. So, I mean, a 1-to-4, or whatever you want to call it, where you have one physician and 4 physician assistants, or the maximum number. So in this bill, that statutory cap has been struck from section 6 of the bill, 3516 sub B. And in section 4 of the bill, however, it adds a cap of 6, but only when prescribing. So I don't know how that would work. So people could have unlimited numbers of physician assistants for all purposes except for prescribing or furnishing drugs.
That was NP
But-
parity. That's pure NP parity. That's what they have. So when we started this whole
Wow.
thing, I'm explaining
Okay.
how we got where we got. So the nurse practitioners only have ratios as it applies to prescribing. If they're not prescribing and they're just doing healthy wellness checkups, there could be 47 NPs to one physician. So that is how that happened. That's
So-
most of all PAs prescribe. Maybe more nurse practitioners don't. Maybe they are doing more wellness and whatever. But that is why that happened. We went in with, we want parity with nurse practitioners. So that's how that got there.
so, well, I don't, I just don't get that, I guess. I mean, I don't understand why we couldn't just change what we have. Why did we copy something that's like based on a kind of a different model? So, but I mean, that's kind of kicking the horse there, I guess. So,
Yeah.
okay. I did have another question about the additional pharmacy training, pharmacology training required. The accrediting body for PA programs requires fairly extensive pharmacology.
Is it the controlled substances course we're talking
No,
about?
the pharmacology course.
The additional pharmacology course that's separate from the
No, I
controlled
agree, that would be
substances?
included in a program.
Okay.
Well, it's been added, though, to the statute at 3502.1 F1 in section 4,
Yeah.
that you have to satisfactorily complete a course in pharmacology covering the drugs or devices. So if it's already something that's covered, why was it added to the statute?
Not sure.
When you add something, there's a presumption that you're putting a new requirement in it.
Exactly.
So
That
that's
will
where we were
definitely take care
confused
of that.
about, so that you're gonna make them do the pharmacology course and satisfactorily, which I'm not sure what that means, completed. And then there's this other course for Schedule 2 that it would be done in a renewal, every renewal cycle. So that's more requirements than currently that I see.
I agree.
What was the pharmacology course? I mean, was it different than what we already do, or what was the reason for that?
I don't know why that was put in there. But when I read it, I assumed that somehow we could modify that to say that it's already been included in the PA program course that they've completed.
Or just take it out.
Or just take it out, or just strike it.
We need to take it out.
Can I ask a question, going back to 3516B? I noticed that provides that the medical board can restrict physicians to supervising PAs within their field of specialty. Why don't we just add a C, if you will, that gives our board, the ability to restrict PAs from practicing outside of the field of specialty of the supervising physician? It seems to solve a lot of problems, unless you think that's too restrictive.
Well, we already have that in regulation, but my point was they struck our authority to do regulations
No.
at all.
That's why
So-
I'm suggesting putting in a 315C that would restore
Yeah.
it.
But I think
To fix
Well,
the thing.
why-
Yeah,
yeah,
don't take it
why-
out.
The other-
Not just
Why
that.
strike it in the first place?
Yeah, no, we need to,
Yeah.
that's scary.
Okay.
Okay, go ahead.
You can go ahead, it's fine. We covered the same things, just in different order, I think.
Right. So the biggest change I saw was the removal of written guidelines, countersignature, and medical records review requirements. And I guess the question from a public protection perspective is it's being substituted with just that the supervising physician decides how much supervision should be done depending on the type of services that are delegated or.
NP parity again, that's the way the.
So I know, but again, I think from a public protection perspective, how do we address that? Because how do either board ever discipline or review whether somebody's actually being properly supervised or whether something was appropriately reviewed? And I guess again, I go back to the model where we like to have minimum standards, and they don't have to be like cookbook specific, but something that would just give general basic objective criteria for supervision. Like we expect that when someone's practicing beyond their scope or needs assistance, that they are required to consult with their supervising physician. Something like,
That's in current, current regs. There, what is that?
Again-
Bob found that sentence today. But the point is, again,
Mm-hmm.
nurse practitioners say they shall work with a physician. End of story. So that we were trying to get more broad for all the reasons that Sonia cites. We were trying to, you are a professional, you will decide, the physicians with whom you work would want you to be partners with them, and they would decide that Jed's an 18-year PA, he needs to be supervised very differently than a new grad, and that should be determined at the practice level. And the practice has a real vested interest in ensuring that those kinds of systems will be put in place.
and I think that I work for the state in the regulatory body, and what we're looking for from a regulatory perspective is to be able to justify that we feel that we still have control over supervision, control over medical services, and the ability to objectively enforce criteria. And because the nursing board has done it differently, I don't know. But for this board, I guess what I would like to see is that they retain the authority to continue to set those objective criteria, and that if this goes forward, that there are criteria that the board can enforce. And the way it's currently written, it kind of looks like it's just the supervising physician's decision about how much supervision should be done in under any circumstance.
I agree that it should be the supervising physician that determines that. But again, you have to have a fence post, right?
Yes.
Like you have to have a boundaries. Like
Right.
it at least has to include, what do you do in an emergency? Something like that. So that when they craft this agreement, they know sort of what sort of things to address so that, and then also we can look at that and say, if there's a problem down the line, well, you didn't even do these minimum requirements we laid out in the regulation to meet this. Does that make sense? Like
Well, it does.
some
In the
framework.
DSA now, it says you must dial 911, in a
I'm not-
whatever.
yeah.
But again, it should be in the practice agreement, If the practice wants to say 5% of the charts, 100% of the charts, every Tuesday they sit down for 4 hours, the practice knows that best, what
Right.
they should do.
Right, but what do you do for those 1% of people who say, I'll call you once a year on Christmas, and that's good?
Yeah.
You know, I mean, that's, you have to sort of have a plan for people that are clearly doing something that is inappropriate, right? I think that's kind of where that goes, is particularly.
I have a question. So let's say once a year at Christmas, but there were no bad outcomes and the most excellent care was being provided and every patient was happy and healthy. Would that matter if they only called each other once a year at Christmas?
Again, you're only talking about one person, but laws are for lawbreakers. So we need to make sure that we have laws in place so that we don't find any issues and we can't do our jobs properly. So I think a couple things that we need to just really consider is that we were created after the medical model. We are not trying to throw that away. We need to enhance that going forward in 2019 and beyond. We are not nurse practitioners. We do not seek to be nurse practitioners, but we want a profession that we're able to practice in the coming years. If we continue this way, we will not. And we will not thrive. So I think we need to sit down, recraft this, because this, again, parity is one issue. We're trying to do our jobs better and more efficiently, but we are not trying to craft the same legislation as the nurse practitioners. And this is what this is. And this is the reason why we cannot agree with this and won't agree with this. But what we need to do is sit down and craft something after the medical model that we've been designed from. Very rich past, but, and so we need to get to something where we can progress in the future without killing our profession. So we have work to do.
Well put again. Thank you, Sonia.
I'm happy to keep going through things, but it sounds like we've all identified several things that don't work well for us in the bill. So maybe.
And don't work well for us in the bill
Right.
either.
So maybe a better way moving forward would be for the board to authorize someone to work with CAPA on this language. Is that?
Well, I mean, are you gonna take a position with respect to anything that we've discussed today? Like, is there anything that you feel like that has to be amended for you to be able to even work with it? So, I mean, it's harder to say you're gonna work with somebody and then the legislature thinks that there's not an issue with the bill going forward. So that would be the only concern I have, is that you miss your opportunity to make sure that some of these big ticket items that really could affect your jurisdiction and your ability to protect consumers be addressed.
Could I make a request? So we just got out of Business and Professions, the first committee. If we can work with you guys, if you could do a watch or neutral, and we could work with you guys before the next committee or before the floor of the Senate. There's many, many more hurdles that you can take a position on. But you have our word, and my word is worth something, I promise you, even though. Anyway, you have our word that we'll work on this before it reaches the Senate floor, which is at the end of May. And with that word, we would hope that you would work with us, and you have many other opportunities to take a position.
Well, and a position isn't final, right? Like, it
Right.
doesn't matter what position we take.
It isn't.
It's not final, but I think, I think we should talk about that. I certainly think, there's really two parts to this. One is, do we want to take a position on the bill? And two, do we want to appoint someone who the board has given authority to work with the authors to make amendments so that we can address the public protection concerns that we have as it's currently written, right?
Right, and I just want to make sure that also another option would be that you could take a position and then you can have another board meeting between now and August, because if you wait till August, you will lose your opportunity to change your position or even affect the bill going forward. So I do want to make sure the board is the one making the decision on what they think should be amended with the bill. And it could change again in another month. And so that's why I'm thinking that you might want to consider, you could take a position now and then hold another board meeting between now and August when you're available and do, it could be a teleconference. You wouldn't have to come here to have the meeting, and then you could change your position or take a position at that time as well.
Jed, I have a question. We're looking at a bill here that's been lined out from a previous version, and you're asking them to put back in what's been lined out from a previous version. So my question, what's the process? Like, you want to take it back to the business profession, would the author have to go back and revise the amended to the original? And
No, we've made it out of Senate B and P, and so now we're gonna take all of this back to our board and make some, and hopefully work with someone from this board in the next 2 to 3 weeks, so it would be amended again before it went to the full Senate floor.
And
I
that's in May.
understand it'd be amended, but are you going to amend it back to the original? I'm just asking, what's
You
the
don't
process?
know. Yeah, the amendment can go any
No,
direction.
and
You
I'm
could-
just
you
wondering
could-
if the author is going to say, you know, this has been changed so many times, I'm withdrawing my
She could,
support.
she totally could say that. She could say that. My hope again is if you, whatever position you put on there will be reflected quickly. And if we can work quickly and then reflect a position that's, that's my hope.
Jed, I make a motion.
Motion.
I make a motion that we oppose unless amended, with the additional caveat that between now and our August meeting, we have another board meeting in Sacramento. Teleconferences don't work.
I second.
Can we add a date for that meeting while we have everyone here?
Would you consider a support if amended?
Right now, oppose unless amended.
The problem with the support position is that this essentially guts our authority. And as a public protection body, it's difficult for us to support something that removes our ability to protect the public, right? Like,
Get it?
it's just really difficult to do that. So,
Monday, July 16th,
that's a
July
Tuesday.
9th.
I think those are Tuesdays.
Could it be in
Oh, I'm
June?
sorry. Monday, July 8th, Monday, July 15th.
Can it be in June?
June.
The legislative process, so we're gonna get out of the Senate on May 31, and we go over to the Assembly side. So if you're gonna change your position, because we make amazing changes to this, the sooner you can change that and reflect that on the next analysis, the better. So if you're willing to do it sooner,
First is the day after tomorrow. We need a little bit of time.
June, no, tomorrow's, or May, if we could do June, early June.
Yeah, for the first week of June.
Ask a question. In the Senate, is it, what reading is there, the first, second, or third reading?
Reading now. It's going to appropriations next, and then once it makes it out of appropriations, it goes to the Senate floor before May 31. Then it goes over to the Assembly side.
Right.
So if we can make changes that make you happy, the sooner we can get that changed position to either a support or neutral because of the changes we made, the better it will be for the bill. The bill will survive a lot better if we can change that position earlier.
Jeez,
Looking for Mondays.
it'd be tough.
So they go out Friday, May 31st. It has to be out of the Senate.
Senate floor by May 31, and then it goes over to Assembly.
How does Monday, June 24th look?
I can do that. I don't know what the other numbers.
What's the date again?
June 24th.
I can do the 24th.
I will try my best.
That is literally the only Monday I can do in June.
Okay. I'm available.
We need to have a quorum, that's why I'm asking.
Yeah,
I cannot be present.
you can't.
I can do June 24th.
Do we have to do a Monday? I'm just asking.
No. I am not available 8 through 23 due to the military.
Right.
And then I am gone the 25th.
June 25th?
Mhm.
So early June, then, if the first week in June was possible?
I have a contractors board, but I
Oh.
could have someone else sub in for me.
June, does it have, if it's not, when does your meeting end? How about like,
So tell me what's wrong with June 24th. Let's go back to the 24th. Who couldn't make it? Or we have two people?
Armenta could-
Oh, okay.
one,
I can do
two,
it.
3? Jen, are you available that day?
21st, no.
1, 2, 3, 4. Charles, are you available the 24th?
Yeah, I'm here.
So that's 5. That's a quorum, right? Is that 5?
5, yeah.
And possibly Mary
Mary.
and Javier.
Javier.
Yeah. But we have 5 here that can make it that day.
Yeah, so you're good.
Then we would have a quorum.
Yeah.
Okay. So June 24th. So I'll add that to the motion, that we'll add a meeting Monday, June 24th. Add it to my calendar now before I schedule something else.
Is that an all-day meeting, or, I mean, how's
Uh,
the meeting
prob-
set up?
we'll make-
Conference call, or?
Well, Mr. Sachs doesn't want to do a conference call, but that is an option. Do that legally.
I mean, I defer to everybody else, but I've never had a good experience with a complicated conference call. Plus, if we have one person not show up at the place that they designated as an address, then the meeting doesn't happen at all.
So the
true.
June 24th is a live meeting? Oh, I thought it was,
Well, that is an option, but it doesn't sound like a popular option.
Well, we could certainly provide, we could provide a call-in number if,
Yes, I mean, sorry, my microphone's not working. So, yeah, I mean, all you have to do is designate a physical location on the agenda. You don't have to be tied to that location, so we'd usually put, well, obviously, there's this location, and then whatever location you want to call from would just have to be open to the public. So we don't want people calling from their house, or their car, or their cell phone.
So-
That those
so-
don't count.
So
But
that
in the
would be a
past-
hybrid meeting, alive with people ability to call in, because that I could do if there's a quorum issue.
No, it would have to be, you'd have to designate the location you're calling from as a place where the public could come and attend in person with you, because for staff and I, we can call in from anywhere. But the Open Meetings Act requires the public the right to have in-person contact with a board member. So when we do teleconferences, wherever that teleconference location is, we have to allow the public in.
No, I understand that, but I thought you were talking about doing it June 24th live, plus the ability to call in.
Well, I suggested that, but there's been disagreement about whether we're gonna do that or
Oh,
not.
okay, all right. Well, the only reason I mentioned it, if you did it that way, I could. I just have commitments in the late afternoon
Okay,
on the 24th.
so I don't know, it's up to you whether you wanna do teleconference or a all in-person meeting, so.
but I think what I'm not clear on is it's a one or the other. You can't do an in-person meeting with a board member calling in.
No, if there's someone calling in, it's a teleconference meeting.
Okay,
So, I
okay.
mean, 6 people could come here and 1 could call in, that's still a teleconference though,
It is.
because someone's calling in and they're not physically present. And so whoever's calling in, that location they're calling from would have to be on the agenda, that's all.
Oh, okay.
But they'd still have full voting privileges?
Correct.
Yeah, so we could still do that then. It's just
Yeah.
called a teleconference, even though there's 6 people, whatever,
And one
here.
calling in,
And
it's
one
still a
calling in, It's called a
teleconference.
teleconference.
Yes.
Jed, why don't we have as many come here
As possible.
as possible?
And then if you
then
can't-
if one can call in, that would be,
Yeah,
You
I
would
can
just
do
have
that in
to
case we.
commit to making
Yeah.
yourself available at that location, wherever it is.
Not a problem.
In a public location.
Yeah, it'll be my
Unless you
office.
want
Your
Not a
office,
problem.
your
Yeah,
conference room in your office
Yeah,
or something.
that's fine.
Yeah.
Okay.
Jed,
That
will a person from the board still be assigned to be available to us to really work through this in
I
these
think that
coming
was the
weeks?
second part.
Oh, okay, good.
Yeah, that was,
Do the first one.
do the first motion,
Okay.
which is position on the bill and another meeting to discuss the position on the bill. Monday, June 24th.
Right.
So the motion was
To oppose unless
to
amended.
oppose unless amended and to set another meeting to discuss the bill June 24th here with the ability for some board members to call in as needed.
Right.
And we have a first and second on that?
Yes,
Okay.
Mr. Saxon.
Mr. Sachs and
Martinez.
Mr. Martinez. Go
I have
ahead.
a question. So this bill is stated 425. That's going to go out of the Senate on May 31st.
Well, with God willing, yes, we have to get through appropriations and then we have to get through the Senate floor.
Right. And then at the same time, somebody's going to be working on amendments to the bill, and then we'll discuss it on the 24th. So the amendments will not be in the Senate, but they'll go to the Assembly.
I feel like we need to move quickly, and so CAPA personally, I feel like, we're gonna have to talk to our board, but I think we're gonna want these amendments made before the Senate floor.
Right.
Like, we need
That's-
to do, especially if you guys, yeah. So I
That's what
feel like
was
these are gonna be
thinking
made quickly.
Is this has to be amended before it goes,
Correct.
To the
Which is
Senate floor.
the next motion will be to appoint someone from the board to work with CAPA on the amendments.
right, but if we're not meeting till the 24th,
Yeah,
is the board going to have any input on the amendments?
Right.
Oh, I see what you're saying.
well, the input will be these meetings that we're going to have. That will be the input. And it would be nice if someone was empowered to change the position if the input was correct, but I get that you can't do that.
No.
So.
But so what effect does that have on your bill if the boards, so what I'm thinking is the board appoints someone to work with you on amendments so that the board could change their position to support. Is it going to cause you a big problem if that position doesn't get changed until June 24th?
Yes, a very big
Yeah.
problem. But I get why I didn't realize you guys were meeting live. I thought you were just gonna have a quick phone call after this
No
wonderful.
such thing.
I know. After we've been able to work together and come up with this solution, that phone call would be rather, maybe not quick, but I know, okay. But yes, the longer your position remains on the analysis as we work through, the worse it's going to be. And it could be very detrimental, and I get it.
Well, and I think we have to also take into consideration the medical board hasn't taken a position yet.
Yeah,
We're going to be at their meeting
next,
Thursday,
a week from Thursday.
yeah.
the 9th.
When do you need us to, when is the deadline that we need to make sure that we have all the changes in place to go to the next meeting for you in May?
Well, again, the next one's the Senate floor. I don't know that you're going to be able to do anything that quickly. If you take this opposed position, opposed to a support unless amended, if you're taking an opposed unless amended, and I get why you have to do that, I really do. The sooner we change that
And
along
that's
the
in May.
process.
May 31st, is that the date, May?
Yeah.
Change your plans.
All right.
What, I still have a further question. What is the sponsor going to say, the senator, if she sees that we have opposed the bill and you go back and discuss amendments further? Does it have to go to the Senate floor on May 31st, or what?
That's the very last day it could go there, yeah.
It has to.
It has
So we
to.
have to try other meetings.
But if we tell the author that we're working closely with you guys and that you have some real issues and that we're working to solve those issues, she's going to be open to that. She's open to all stakeholders working together. We will apologize to her too that we didn't do this sooner with all of you, and we'll just do it now.
Jet, are you around on
And the
May
medical
20th?
board meeting, is that next week?
I can make May 20th.
Medical
Conference.
board
Yes,
meeting?
the 9th,
I
the
hate
medical board is May
conference
9th.
I know, but I can be here. I'm here, but so I'll come here for it.
Or I could come here.
So, yeah, we could do May 20th.
How many people could do May 20th?
I don't know, Bob, with my busy schedule now.
Final decisions should be delegated to
You turn the camera off for a minute?
two persons. It's
Oh,
just
Bob, I'm available May
change
20th.
and Giving advice, they aren't authorized to make a change. They would be just.
Oh,
I don't think the
no.
public can come in.
No.
Yeah, they couldn't come without a boarding pass. That would be expensive.
Yeah. Right, but they wouldn't, You wouldn't have the final say on whether the
No.
position changed.
No, but they would have the final say in terms
Yes.
of what,
Yes,
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 okay,
one person.
okay. So, changing the motion again to reflect May 20th instead of June 24th, is that correct? Everybody's
Yes,
checking?
but Jen said she can't make it.
That's AAPA, Jed. 20th, you said?
Who goes to APA? I'm just kidding. Yeah, I'm not this year, that's why I'm saying that. Okay, how about, Sonia, are you gonna be,
I think I might be available, yes.
okay,
Okay.
I'm
Xavier?
available.
Okay, you are.
I'm available.
I'm available.
I'm not gonna be available.
He's not available May
so we'll
20th.
have
One,
one,
two,
me,
three.
Bob,
You've got 5.
Sonia, is that 5?
That's 5.
Yeah, it's 5.
Okay, and maybe the two people who aren't here today, as long as we have a quorum.
So now we're looking at May 20th?
Yes.
A time?
I like 8 o'clock in the morning, but
I knew you were gonna say that.
I'm sorry, I'm a morning person.
I'm not a morning person.
I know. Okay, well, whatever time works for you guys, 9,
8:30?
8:30 I can do.
What?
Monday is my clinic day.
How long of a meeting you think that will be?
An hour at the most.
the only item on the agenda will be this bill,
And
So,
hopefully the person
so May
who's
20th
assigned
now?
to us,
May 20th.
we will have gotten to a really good place, and it really hopefully would be we've worked closely with Kappa, we're happy with the bill, or we've worked closely with Kappa, we're unhappy with the bill.
So we're gonna do it 8 o'clock?
8:30.
I'm
You
being
people-
good by not saying 6:30.
You people need to get up right here.
I could be back in LA by 5, I can make it, but
Yeah, it's gonna be a short.
8:30?
8:30,
8:30.
8:30, May 20th.
Julie's gonna have to find a room, so there's a possibility we might have to.
What about the department? You could
Well,
check
that's
the
what I'm
department.
thinking. If we can't get something here, I'll have her look there.
Or even, you could ask even like accountancy board, they have a meeting space at their location.
That's true. It's across the street, huh?
No, they've moved.
Oh, that's
So-
right.
It's a very swanky
Oh,
facility,
question.
actually.
We're not coming up here on the 20th, we're just doing a phone call,
No.
correct? No, we're coming up
This
here.
is a live meeting, right?
Well, we give people the option to call in.
Yeah,
Okay.
they can call in or come up.
Yeah.
It's
Okay.
technically a teleconference, but as many people as can make it should.
Yes.
Okay.
You could, if you wanted to, just do a conference call.
Well, they will have everyone will have the ability to call in, but there will be at least, I just want to make sure we have a quorum so that the board can change a position if so desired.
Yeah.
Okay, so the motion is oppose unless amended with a meeting to be held May 20th here with teleconference.
Yes.
Further discussion? Public comment?
Thank you very much, and again, I apologize that we didn't do this sooner.
Okay, should we call the roll, Julie?
Yeah.
Charles Alexander,
Aye.
Juan Armenta,
Aye.
Jennifer Carlquist,
Aye.
Sonia Early,
Aye.
Javier Escobar Costa, Jed Grant,
Aye.
Xavier Martinez,
Aye.
Robert Sachs,
Aye.
Mary Valencia.
Motion carries. Next motion would be to appoint one person from the board to work with Kappa on making the requested
Amendments.
amendments to the bill. And this person would be authorized to speak on behalf of the board for making these amendments. Doesn't change the board's position, but they can speak on behalf of the board with Kappa to make the amendments.
I'll have to make an amendment or a motion that you are that agent for us.
Our
Love
second
it. You
that.
do know the bill, though. I mean, he just knows it.
Yeah, I'll just cancel my plans. Okay, that's fine. Okay, so the motion is, I will work with Kappa to make the requested amendments to the bill prior to,
Is there a second? I'm sorry.
Second. Second.
I second
Okay.
I thought
Doctor.
Dr. Alexander seconded?
it.
Okay. To make the requested amendments to the bill prior to the meeting on May 20th. Okay. Further discussion? Public comment?
Thank you.
Thank you.
Okay, Julie. Dr. Alexander.
Charles Alexander,
Yes.
Juan Armenta,
Aye.
Jennifer Carlquist,
Aye.
Sonia Early,
Aye.
Javier Escobar, Ted Grant,
Aye.
Xavier Martinez,
Aye.
Robert Sachs,
Aye.
Mary Valencia.
Motion carries. Okay.
Thank you
Sounds
very
like we'll be
much.
talking a lot in the next few weeks.
We will, and we'll make it easy and convenient for you.
Okay. Stop laughing, Lynn. Okay. Okay. On to the next item on the agenda. Thank you, everyone, for that work, which is the
Regulations.
regulations update. And that is Anita?
Good afternoon.
Hi.
Hi. We have a regulation that we want to change, and that's item A in the regulation list, and I was wondering if I could do an update on our existing regulations before we went into discussion on item A, if it was okay with you, Mr. Grant.
Sure. I'm not following you. Item A.
Okay, so if you look at section 13.
Oh, 13A.
13A, sorry.
13.
Where
I
is
don't
the
have a 13.
discussion?
On the agenda.
Oh, on that. I
So
got you.
13A, she wants to do these first. They're just updates.
Oh, you want to, okay, got it.
Yeah, the
Okay.
updates for the summary that I normally do for you is very, very quick.
Okay,
Everything is as on the document that I gave you, with the exception of 1399.617, which is audit sanctions for noncompliance. That's our CME regulation.
Right.
It's been approved by agency.
Good.
It has been submitted to OAL for final filing with the Secretary of State on April 18th, which means barring any errors on my part from AOL saying to me, you did this wrong, we should have an effective date by July 1st of this year.
great.
Which means, so that's the only change that I had to that particular, everything else is as the document states.
Well, that was a lightning fast.
All right.
That one was fast.
It actually was really fast.
That
It was
one
a
was
year.
less than 18 months.
Yeah, it was just barely over a year. March 6th.
That's sad.
March 6th, and
Fast.
that will be in May sometime. So that's 14, right? 14
Well, it will
months?
be effective July, but
Okay, but-
we submitted it in April, which is 13 months.
Yeah, that's great.
So
I mean,
that
that's
was pretty,
fantastic.
yeah, we worked.
I thought I was being sarcastic.
Oh, I
though.
did.
It was actually not being sarcastic, which is rare.
Okay. So during the course, we're all very familiar with AB 2138 and how it affects our asking for convictions and whatnot. We learned in the interim of doing 525, 26, and 27, which has to relate to criteria, we have found that it now affects our registered sex offender regulation. So what we're trying to do is separate out applicants who are registered sex offenders versus existing licensees who are registered sex offenders. So we amended Section A of the regulation to remove the words deny, because you can't deny somebody who's already licensed. So that would make that Section A just for licensees. And then we added in a section for applicants to accommodate and maintain what we're putting in 1399.526, which is setting up rehabilitation or the criteria. So by adjusting this, we're separating it into two sections, one for an existing licensee and one for a new applicant. Did I get that right?
Yeah, let me just give a little background.
Thank you.
So this regulation was first adopted in 2011. At that time, there was a push from the Department of Consumer Affairs to implement something called the Consumer Protection Enforcement Initiative. And one of the regulations that the department suggested the Healing Arts Boards adopt is a regulation that prohibits sex offenders from being licensed or from continuing to be licensed after they've been convicted and required to register as a sex offender. So this regulation is the regulation at that time that was suggested and proposed and this board adopted. And what it does really is it's sort of an automatic denial and an automatic revocation for licensees or applicants who are convicted sex offenders. And we fast forward to 2018 and Assembly Bill 2138 was enacted. That's a change in policy. And that bill says that the boards are not allowed to deny an applicant for licensure who has made a, quote, showing of rehabilitation. So this regulation doesn't take into account rehabilitation evidence. So we have to change it at a minimum to allow people who have made a showing of rehabilitation to be considered for licensure. So right now, the way I've drafted the amendments, and it's just an idea, is at a minimum, these changes would still permit you to revoke the license of a person who's become a registered sex offender and to deny anyone who's petitioning for reinstatement automatically from being reinstated. But for applicants, you would have to have them go through the normal process of applying and giving you evidence of rehabilitation to determine whether you could deny them, because Assembly Bill 2138 doesn't allow for automatic denials anymore. It won't effective July 1st, 2020,
What's the definition for rehabilitation?
So your regulation, we actually discussed this morning. 1399.5 to, let's see.
Rehabilitation is 526.
6
isn't it?
and 527. So 526 covers applicants and 527 covers licensees. So in that regulation, which we discussed at our last board meeting, you're required to look at a variety of factors and criteria, including the nature and severity of the offense, how long the time has been since the offense occurred, any evidence of rehabilitation, meaning evidence that essentially they're not the same person that committed whatever the act or offense was that was grounds for denial or revocation, and that things also like whether they have expunged convictions or they've had convictions set aside as a result of a dismissal order. So those are your current criteria in regulation. So these changes would not affect your ability to deny somebody a license if they're a registered sex offender. It just means you couldn't automatically deny without first considering their rehabilitation evidence. So that this is one option. Another option could be to repeal the whole thing. If I know I'm looking at you, but I don't want to presume where you want to go, because this is a policy decision. And I simply amended it consistent with the board in 2011's policy. I don't know what the board in 2019 wants to do with this policy. So this is a suggestion. I don't want to make it seem like this is your only legal option. So I'm just putting it out there. I got a look from Mr. Grant, but honestly, I don't want to presume which way you may want to go. You could decide, we're going to let everybody give us evidence of rehabilitation and decide these cases on a case-by-case basis. Or you could say, look, for licensees and petitioners for reinstatement, we're not going to consider them for licensure, and this regulation proposal would accomplish that. It would only allow, pursuant to the current change in law that would be effective July 1st, 2020, for you to consider rehabilitation evidence for new applicants for licensure.
Which the bill requires,
The
right?
bill requires it, so that's why I made these changes. So you'll see in sub B, 3 and 4, the two things you cannot do under AB 2138 is deny somebody who has obtained a certificate of rehabilitation. And I don't know if you're familiar with these, but you have to file these with the court, and you have to put out an affirmative case that you're rehabilitated. So they're very hard to get. And then also anyone who's been granted clemency or a pardon by a state or federal executive. So the bill says you cannot deny, someone a license who's obtained one of these three things. Then the fourth thing the bill does is it prohibits you from denying someone a license who's made a showing of rehabilitation. We just discussed that. So I've amended the reg to state that it doesn't apply to someone who has met those criteria. Then if you go to the next item, item 5, I just, consistent with the new law, changed the effective date to July 1, 2020, because that's when AB 2138 will become effective. And then sub C, I've just kind of made it clear, in case we get someone that likes to be creative, that even if someone tries to reclassify themselves as an applicant when they're really a petitioner for reinstatement, that the benefits of, getting that ability to show the evidence of rehabilitation don't apply to a petitioner for reinstatement. So, for instance, you wouldn't have a situation where someone would be automatically revoked for becoming a sex offender in this reg and then come right back through reinstatement. But again, this is just per your prior board's decision on how you want to handle registered sex offenders. We can always change it further if you like, but this is just the minimum you would need to do to comply with the new law. Any questions?
Well, we really can't be any more aggressive than this.
No, you can't.
This is as conservative as we can be, if I understand correctly,
Yeah.
based on the new law.
The question is, do you want to be more
Liberal?
liberal? I don't want to say, I want to say more open to allowing people to present evidence of rehabilitation, no matter what kind of crime. So that would be that's the question. And so, again, this is a conservative approach and the minimum required, in my view, for compliance with the new law. But you could go farther in you could repeal, or you could maybe allow petitioners to do it, or, you know what I'm saying? So
Yeah.
there's just a lot of options, and I don't want to make it sound like this is the only way to deal with AB 2138.
Further discussion?
Anyone?
Let me just make sure I understand. So they've already been convicted, and
Yes.
so once we get their information, we are basically really consenting on their ability to do their job as it relates to their conviction.
Well, no. If you're a sex offender, what this reg says, you can't be a physician assistant. That's what this regulation says. And it's been in effect since 2011. What's changed is that we have a law that's effective July 2020 that says you can't do that to new applicants. But what I'm saying is you could go farther and extend AB 2138's concept to licensees or petitioners for reinstatement. It's up to you. But if you just want to keep it to the minimum in the law, which is applicants for initial licensure who are registered sex offenders would be allowed to present evidence. If they still don't prove to your satisfaction that they're rehabilitated, you could still deny them. It's just that under this reg, it's just an automatic denial. There's not even a weighing of rehabilitation evidence.
That's for the licensees, right?
That's for applicants and licensees and petitioners. But under the reg proposal I have in front of you, it would just be that we wouldn't do that anymore for applicants for
Well,
licensure.
either way, I think we need to make a decision because this should go back to the school level. Since now we have almost 20 schools in California, we need to make sure that they know this before they even put $100,000 on the
So,
line that they can't practice. That is unfair and unconscionable. So,
I can address that. So, most schools require a background check. I think all.
Yes,
I
they do.
verified that. Require a background check before the applicant matriculates.
Yes.
And then do it again before they enter clinical rotations. And most, if not all, clinical sites will not allow 290 registrants to rotate there. So most schools have a bar to admission if you're a 290 registrant, just because they can't meet the requirements to complete the education. So that's already happening. I think this mostly has to do with someone who's had a pardon or clemency or has a new conviction
After they've
been licensed, those sorts of things. So my understanding, correct me if I'm wrong, is that this is the most conservative way.
Yes,
It's as close to what we do now as we can be under the new law.
correct.
Okay.
So with that regard, so entrance is not a problem, which is great. Even if they are convicted on, they're supposed to identify that to us and let us know that they have now been recently convicted, correct?
Not
They
if
apply
they're
for
an
licensure?
applicant.
No, so during any time that they are cited, say for instance, they're in their,
On renewal, they would.
say for instance, they've completed their first year of their PA program. And then they are cited for a sexual offense. They are supposed to notify us at that point of their conviction, correct?
Not the PAB.
Not the school, not
No,
us.
they would notify the school.
The school.
Because
Right.
the school is having to get background checks for their
Exactly,
rotations.
constantly. So with that, I work at a school too, so I'm wondering, with that, we are supposed to notify them at that time, maybe cease and desist, they can't further.
They're not going to get a license
Right.
with the board.
And they're not going to be able to complete their rotations, means they can't
Exactly.
graduate, so they can't sit for the
Exactly.
pants. and-
Exactly.
Well, this would be the change for the schools. Under current regulation, until July 1, 2020, they cannot get a license, no matter what. When July 1, 2020 the law goes into effect under AB 2138, there's a possibility that they could, because we cannot automatically prohibit them from having a license, because we'll have to comply with the new law for initial applicants.
Where they have to show proof
So,
of
but there's really,
rehabilitation.
they should know there's a risk that they won't get licensed because of that background.
Right.
So that's the difference. Right now, they absolutely cannot get a license, but effective July 1, 2020, there's a possibility, because if they make a showing of rehabilitation, by law, we cannot deny them a license.
So let me ask you this, so after July 1, 2020, you have a PA who's been in the field for 10 years and then becomes a sexual offender.
Right? They
So
would be
now what?
automatically revoked under this
They would be
regulation.
revoked, okay.
Automatically,
Automatically, okay.
Which is the same as it is now.
which
Right.
is the same it is now,
Just
unless you
new.
decide to change the regulation.
Wow, okay.
I know it's big, so that's why we're bringing it to you.
So,
How do
Is
you
it-
feel about it is my question,
well, I like it.
the way it is.
Well, yeah, but I mean, we have to stay, I like option one here, which
Okay.
keeps us as close to how we are now.
Okay.
I mean, we have to comply with the legislation. We don't
Correct.
really have an option.
No.
So,
I just foresee problems if you have an older, you have the new new legislation for the new applicants, and then say the old applicants have an issue. That's just, it's not the same. So I think that's going to be a huge problem if that happens. But I do like what we have right now.
Okay.
further discussion? So,
You want me to read the motion?
sure. You're talking about option one?
Yes, sir.
Yep.
Well, the only difference between option one and option two gives you the
Changes.
opportunity to change any of the verbiage if you wanted to.
Understood.
Okay. So the motion is to approve the proposed regulatory text for section 1399.523.5. Direct staff to submit the text to the Director of the Department of Consumer Affairs and Business and the Business Consumer Services and Housing Agency for review. And if no adverse comments are received, authorize the executive officer to take all steps necessary to initiate the rulemaking process, make any non-substantive changes to the package, and set the matter for hearing.
Anyone want to make a motion?
Or make the motion.
I second.
So motion by Mr. Sachs and second by Ms. Early. Further discussion? Public comment? The whole public has left us. Okay, Julie, will you call the roll?
Charles Alexander,
Aye.
Juan Armenta,
Aye.
Jennifer Carlquist. Aye. Sonia Early,
Aye.
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 Motion passes. Okay. Was that everything on our regulation? Anita, did you cover everything? Okay. Next is the legislative committee update, the behemoth.
I know.
Yes, it is.
Poor
So
Sonia.
please bear with me. It is 19 issues,
Yeah.
but I will try my best to get through them quickly. First, I want to thank Mary Valencia, who is not here, for doing such a great job in helping put together this wonderful sheet that I'm going to go through. She couldn't be here today, but I do thank her for that. So we are quickly going to try to get through this. We have AB 149. And just briefly, that is regarding our controlled substances and prescriptions. Its status is currently enacted, and just to bring you up to speed, this bill delays the implementation of requirements for the prescription forms as specified in AB 1753. The bill also allows pharmacists until January 1st, 2021, to continue filling prescriptions written on prescription forms that were valid prior to January 1st, 2019. So that has passed, and just wanted to update you on that. So AB 193, that is our professions and vocations. The status is currently, it's in assembly now, as referred to the Committee on Business and Professions. Just to update you, this bill would require that the Department of Consumer Affairs to review all licensing requirements under its jurisdiction, identify unnecessary licensing requirements, and report to the legislature by March 1st, 2023, and every 2 years thereafter. So just wanted to give you analysis on that. Yes,
Yeah,
go ahead.
Can we discuss these as
Yes,
you go
you
through
can.
them and
You
take
can.
a position, or maybe? So, it just seems a little problematic to me. For the department to determine all the licensing requirements for each
Profession.
profession,
Yes.
like that's really going to be labor intensive, expensive.
Yes.
Well, and I wonder if it would put you in kind of an adversarial position with the department over whether they think something's necessary or not for physician assistant practice, and you think it is. So that would be my concern, is what's the ability for the boards and bureaus to work with the department on developing that report so that, it's consistent with your understanding of safe practice and not what somebody else thinks who's not familiar with your practice and not responsible for setting standards. That's your job to make that call. That would be my concern.
Right.
The other thing is it requires every 2 years for your staff, because I assume it would be your staff, to submit a report on the board's progress in implementing policies to facilitate licensure portability for active duty service members, veterans, and military spouses. So I just want to make sure that on page 4 of the bill, that the staff are able to collect all this data and have it. So I don't know if we do. The number of active duty service members, veterans, and military spouses who applied for licensure for each of the previous 2 calendar years.
We collect that information, but if they don't.
Sorry.
We do collect the information as to whether they're military spouse or military veteran.
We do.
We do collect that because they get their application review expedited. And we do put that as a secondary status within Breeze, within their account. If they withdraw their application, though, that data would go away.
Okay.
And the only way it's maintained is if they're actually licensed.
What about the number of applicants who've received a waiver of renewal fees?
None.
None that you're aware of?
None.
Okay.
We don't waive renewal fees. We've waived CME requirements due to hardship or military or
Okay.
illness, but I've never known us to waive a renewal.
No, we
fee.
don't.
Okay, so it doesn't look like, you have these 5 criteria on page 4. It doesn't sound like it would be a problem for you to report that information then? So we're looking at the number of active duty service who've applied, the
Right.
number that have been expedited, the number who've been waived renewal fees, and whether an applicant may apply for licensure by endorsement, which is really like reciprocity,
Which we don't do.
which you guys don't do, right? So,
The only thing we'd have to worry about would be the military plus the expedite, correct?
okay.
Which-
I think what they're
Have
trying
that
to do is get reciprocity between states, but we don't have any control over that. We just control California, right? And we have requirements for our licensure that are defined by the legislature that other states
Yes.
don't do.
Right.
Right.
So it's impossible for us to take, say, a Nevada license and say, oh, you automatically have a California license because they would not met all those other
Right.
People ask
requirements.
us all the time, and we tell them that you have to apply,
Yeah.
and you have to
Yeah.
meet our requirements.
So
So it sounds like the only thing that might be a problem is the department's review of your laws and regulations to determine what's necessary.
which is this, I don't know if this is worth spending some political capital on opposing, but I don't know if we want to take a position.
You could do support if amended to remove the department review of the, because then the other stuff would just be reporting of what you're doing
Stuff
with
we
active
already
duty
have.
service members and
Yeah.
veterans and spouses. I don't know, that's an option, I mean, or you
Yeah.
could just, do a, neutral with the direction to staff just to communicate your concerns. I mean, that's another option too.
Motions?
support if amended, was our other option?
Yeah, I mean, your options for legislation are oppose unless amended, support if amended, neutral, and then some boards will direct their staff to just watch and report to them on the bill's progress.
So basically, we support this as long as
Amended.
they don't let the DCA tell us what our licensees need to have.
Right.
We already do all the other stuff it wants us to, except the stuff that is impossible to do because of this other laws that
Right,
already
you don't,
exist.
yeah.
So,
So maybe a support if amended?
is that a motion?
It is.
Is there a second?
Second.
And the amendments would be to remove the provisions that require the Department of Consumer Affairs to review all licensing requirements, identify unnecessary license requirements for the board, and report to them to the legislature. Okay.
Further discussion? Public comment? Okay, so the motion is to take a position of support if amended with the changes that Christie described. Julie, will you, it was made by Sonia and seconded by Xavier. Julie, will you call the roll, please?
Charles Alexander,
Aye.
Juan Armenta,
Aye.
Jennifer Carlquist. Aye. Sonia Early,
Aye.
Javier Escobar Costa, Beth Grant,
Aye.
Xavier Martinez,
Aye.
Robert Sachs. Aye. Mary Valens.
Okay, motion carries. So the staff will let the author know, I guess? Do you send him a letter? Is that how you do it?
Yes.
Okay, perfect.
All right, moving forward, AB 241. That's our continuing education requirements. This bill would mandate that specified healing arts boards adopt regulations requiring the curriculum for continuing education for its licensees to include instruction and testing in understanding and reducing implicit bias in treatment. The Medical Board of California, Osteopathic Medical Board, Physician Assistant Board, and the Board of Registered Nurses must all comply with new requirements by January 1st, 2020.
Good luck, 2022.
I'm sorry, 2022, yes. Right.
Crazy.
It is
Well,
crazy.
I mean, the concern for me is that we don't really designate content. Designate the programs that approve the providers that do the content. And so it would change the way that you currently set CME standards. You would actually have to get into the minutia of designing the content of the course. So that's the only distinction is, there are some boards that requires core curriculum and content. There's very few of them.
Right.
Most of them do like you do here. So that would be the difference. It would be a departure from how you currently regulate continuing medical education. So I mean, you could just wait and see how this turns out. I don't know if you have any other concerns, but that was mine, that's not currently how we usually don't deal
We
with the
reject
content.
unless amended?
I just
The
think,
question is whether you want to take a position.
yeah, I mean, it looks bad if we take a position saying we oppose implicit bias training, right? That
Yeah.
looks bad.
Yeah, that's right.
On the other hand, we don't want to be in the business of
Right.
prescribing the content of CME. We want to
Right.
let we do that a little bit with a controlled substance course, and that's a little bit of a,
Content specific.
that's content specific and related to a specific law that required it, which I guess we would end up doing the same thing with this.
Yes.
So.
With that, I mean, I know we can only do, that is kind of harsh if we say deny, or change, but we can't be in the business of regulating CME standards in terms of, this is not what we do. But of course, we want, implicit bias training. So do we
Well, I think
support
Maybe you could say something like that the continuing, whatever, providers or approved providers, or agencies that approve CME courses would be directed to do that and not the board, perhaps.
so. We take like a watch position and then have the staff send them a letter saying,
Yeah.
"Hey, this isn't our business."
That
would
maybe
be
should be more properly directed to the providers and not to the
not to the board.
boards, because we don't regulate content.
That way we can watch it if they make significant changes. We're not aware of it.
Right.
Yeah. So the motion would be to watch AB 241 and direct staff to send a letter to the author requesting that they contact CME providers about this and not require boards to do it, as it
Yeah.
is not an area that the boards regulate typically.
Yes.
agree?
Anybody want to make that motion?
Motion.
So Sonia made the motion and Bob seconded. Further discussion? Public comment? Julie?
Charles Alexander,
A.
Juan Armenta,
Aye.
Jennifer Horquist, Sonia Early,
Aye.
Javier Escobar-Costa, Jed Grant,
Aye.
Xavier Martinez,
Aye.
Robert Sachs,
Aye.
Okay, motion carries.
All right, AB 289, that's our California Public Records Act Ombudsman. The status currently is amended and passed the Judiciary Committee. It's been re-referred to the Committee on Appropriations with recommendation to consent calendar. This bill will create the California Public Records Act Ombudsperson, who would be available to the public to review denials by state agencies for request of public records. So thus, it just seeks to establish an alternative way for members to the public to enforce their rights under the CPRA. Do you guys have any?
Yes, I do. So, under the current process, the requester submits a request, and we have 10 days from the date of the request, with a couple exceptions, to indicate whether there are records responsive to the request and whether the records are being denied. And the denial has to be based on express provisions of law or what they call the balancing test, meaning we explain that, there's a privilege or public policy objective we're trying to protect, like investigations, deliberative process, that sort of thing. So this proposal would allow people to essentially appeal to an outside agency who could then review and require this board and others to disclose all of their records, look at those records, and basically reverse order the board to reverse this decision denying the request. And if they do that, then the ombudsman can seek cost recovery for their services from this board for what they consider the improper denial. So I've never seen anything like this where they kind of create a quasi-judicial process for another state agency to review another state agency's actions and then order cost reimbursement to the agency that did the review. The other concern I have is that although it allows us to cite express provisions of law for the reason that we deny the request and that the ombudsman doesn't have the authority to review those provisions, like for instance, rap sheets. It's a misdemeanor for us to disclose rap sheets to anyone, but we get asked for that. We get asked for people's criminal history all the time, and we have to say you can't have it. Even the people that have the rap sheet will ask us for it, and we don't give it to them unless we deny them a license or discipline them. Those are the only situations we can release a copy of the rap sheet. It's strictly prohibited and it's a criminal offense. So under that circumstance, this bill would not require you to disclose it. Where I think there's some gray area is in those situations where we're saying, look, we're not releasing it to you because we don't want you to know how the staff came to their decision on an application or an investigation, basically what we call deliberative process. So I'm concerned about that potentially being forced to disclose, but also just adding another layer of cost. And there's already a process where people can go to court and sue if we improperly deny a PRA request. So I'm just looking at this adding additional layer of cost and expense when there's already an available avenue for appealing a PRA denial.
Okay. So do we have to take a position or?
You don't have to, but I'm just telling you what the concerns are, so it's
So-
up to you whether you think it's important enough to take a position on, so.
So how many, just asking staff, how many public records requests do we get? So would this, and of those that we get, how many do you deny?
I don't think I've ever denied any.
Really?
I haven't had any reason.
You've had no one ask you for your investigative file? That's the most common request we get at the department.
I think we've had maybe one or two.
So
And then yes, we would deny that.
Right. So not that many, it sounds like.
Yeah. But there's already another process, right? They go to court, they say, hey, they said, no, that's not fair, it's mine, I want to see it,
Right, and we'd have to pay their attorney's fees and costs and give them the records
if we lost.
if we lost.
So this takes it out of the court and lets one person do that.
They still get the court process, but they also get this one too. So
Why are we duplicating the process?
that's a good question. They still have the authority to sue. This would not remove that authority.
Well,
They used to get two different, they get an administrative process of appeal through an outside agency, and they would also get the judicial avenue.
Yeah, keep in mind, this isn't directed towards us.
right.
This
Probably
is-
not.
This is statewide, and if
That's
you
right.
try to get some public records from certain agencies that don't want to give up the goods, it's problematic. So that's what that's meant to streamline.
Right.
Yeah.
Yeah.
So maybe we don't want to spend any political capital opposing something that
Okay.
probably wouldn't, I don't know what. do
Really
the
wouldn't
other
have as much
members think?
effect on you, maybe.
Not really going to affect us that much.
Okay.
Right. I
Okay.
agree. Okay, AB 312, that's our state government administrative regulations review. The status is, it's in assembly on April 3rd in the Committee of Appropriation and is placed in suspense file. Just to update you guys, this bill would require state agencies, including departments, boards, and bureaus, to do a one-time review of regulation and identify those that are duplicative, inconsistent, or out of date. The agency would then be required to repeal, reconcile, or eliminate those regulations and report their findings and actions to the governor and legislature by January 1st, 2022.
So this one has a huge fiscal on it. So I don't know how successful it would be because it would require every agency in the state to evaluate each one of its regulations and report on it. I think one of the comments in the bill was that it would impose significant costs on every state office, department, board, bureau, and commission. And several of the larger state entities have cost estimates that exceed $1 million for each of the next 2 years to implement this. Because it would be an ongoing reporting requirement. So I don't know that it's going to go anywhere with
Yeah.
that kind of.
Wasn't there a law like this a few years ago? It seems like I remember.
I think that there was a prior bill and it died. And I think it was Cooley that did that one. Oh, it is the same guy.
Yeah.
I think it was AB 12 or something.
Yeah, that sounds right. Okay.
And then I thought Schwarzenegger, when he first came into office, didn't we have to do a reg report? to evaluate whether we had any obsolete regulations.
Second or third time that it's come up.
Yeah, so it's come up before and it hasn't been successful so far, but
I have a
yes.
question. When it says place in suspense file, what does that mean? I mean, is it, they're not
Usually
gonna
when there's
act
a
on it?
fiscal, they will, no, it doesn't guarantee. It could still come out of the suspense file, but it has to get through appropriations. And with the numbers that are coming through, I don't know how successful it's going to be. But you should know about it just in case.
We're already
it
kind
is.
of doing this. We're just
Yeah.
not reporting to the governor and legislature, and we're not doing it by that crazy deadline.
There's no way 2022 for all of your regulations. Remember, each one of them, if you decided to repeal, would have to have an administrative regulatory package that would have to go through the process. And as we've seen, the shortest one we've had is 14 months so far.
That was
That was
record.
fast.
That was a
Yeah.
record. Okay, so no position?
I don't think so.
Everybody okay with that? Okay.
Okay. All right, AB 358, and this is our sexual assault forensics examination kit databases. So this one's a huge one. I don't know if I'll read it, and maybe, Chrissy, you want to chime in? That's, the bill will require the law enforcement agency that has investigated the case involving the collection of sexual assault kit evidence to create an information profile for the kit only if one does not currently exist. The bill would require each city and county, or state lab that participates in the California Combined DNA Index System, CODIS, upon notification by the department that the CODIS hit has occurred for forensics evidence collected by the sexual assault kit to enter into CODIS Hit Outcome Project, which is CHOP. That database for the information required by the department, and to report to the department as required by the department, the status, the outcome, and the investigative leads. By expanding the duties of the local agency, this bill would impose a state-mandated local program. And it's very costly, and I can keep going on, but I know Christy wants to probably identify some issues there.
Well, I don't know that I want to, but it's, I think what I was asked was what relevance would it be to the physician assistant profession? And I think the only thing I could identify was that the Department of Justice has to develop a system that allows a healthcare provider who performs these types of sexual assault examinations to be able to update the status once the kit's been submitted for their patient in the system, like where it is and if there's been any hits, DNA hits. And also at the discretion of the physician assistant who performed the exam to get a unique login for the victim so that they could track whether there have been any hits in the DNA database.
So who does that
for it.
now? I mean, is it law enforcement that
No,
does it?
they don't do
Nobody
it
does
now.
it now. Oh.
No, and I think there's just been some political pressure to actually move these kits through the process and be able to track them and see where they are in real time. And this is what the bill would be doing. And so there would be some effect on physician assistants that do this kind of work, but it would be pursuant to the program that the Department of Justice puts together. And so they first have to put the program together, and I guess they have to report on that implementation by 2021. And then everybody, all the counties and cities have to be on board by 2023. That's kind of a pretty quick turnaround time frame. And then all that working together, the healthcare system, the counties, the cities, the local law enforcement, would be able to access that information in real time and see whether there's hits and where it is progressing in the system.
Sort of like a cures for a
Yes.
SART kit.
Correct.
Yeah.
Wow.
So I don't know if you're interested in weighing in or just watching or anything. Or just leave it on the list and see where it is at the next board meeting.
We can leave it on the list. I don't know how everybody else wants to.
Anybody want to take a position on this? Okay, moving on.
All right. AB 473, that's the Department of Consumer Affairs Task Force for Foreign Trained Professionals.
476?
476, yes, sorry about that. This bill will require the department to establish a task force to study, and again, it's a task force to study the workforce integration of foreign trained professionals. The task force would be required to solicit input from a variety of government agencies, including in-state and out-of-state licensing entities. So again, it's just a task force, so I don't know if we want to take a position on that.
Yeah, the task force would be, one of their tasks would be to evaluate whether any of this board's licensing standards are a barrier to integrating foreign trained professionals into the licensed workforce. But again, this is just the concept for a study at this point. So, I mean, you could watch it to see if it develops into something else. But for now, it's just a study to establish a workforce, task force to study this issue.
So I would just watch. I wouldn't want to dedicate, yeah. Okay. All right. So AB 521, I don't think that applies to physician assistants. I can go through it, but I can skip it. Okay. AB 544, that's our,
Does that apply to PAs or no?
Well, what happened is originally it was going to deal with, helping train physicians with dealing with firearm-related injuries and deaths, but then it got amended on April 10th, and it became the study for the University of California, so we didn't really think that it had a lot of relation to this board's, so we didn't think that it was worth getting into the minutia of it, but we can.
No, just wanted to make sure. As someone who's had a lot of firearms training, I was curious about
Yeah,
that.
I mean, it started out being, like you said, it would have been of interest if they were going to put in standards for physicians to do that kind of training, but it changed on April 10th.
Okay,
It's a very popular day for amendments, so.
certainly.
so what changed? What did they say? They just didn't
It
want
went to this University of California resolution and study about training in programs. So we didn't really feel like it really would affect physician assistant practice in any way, so I don't know. That was what we were thinking, Mary and I were thinking, so.
Okay. All right, AB 544, that's our professions and vocations, inactive license fees and accrued and unpaid renewal fees. So the status is in assembly. It was re-referred to the Committee on Business and Professions. This bill would limit the maximum fee for the renewal of the license in an inactive status to no more than 50% of the renewal fee for an active license. The bill would also prohibit a board from requiring payment of accrued and unpaid renewal fees as a condition of reinstating an expired license
Yep,
for registration.
right.
So,
So this would have a direct effect
Cost.
on your line, budget line item. Right now, you charge the full fee for inactive. The only benefit to inactive status is they don't have to pay the continuing medical they don't have to take the continuing medical education. So there would be a 50% reduction off the top in revenue for that status, and then you would lose all of your delinquency authority to charge a delinquency fee for an expired license. So there would be a revenue impact there. I don't know how bad it would be for this board, but it would affect all the boards in the department. There's one board's taken an opposed position. The Speech Pathology, Language, and Audiology Board has opposed it because it'd be less money to protect the public and to maintain standards of licensure, and also they thought it would be a disincentive to keep licenses current, but there would still be a workload to the board to regulate those licenses. So that was their opposition to this bill. I think the same concerns would apply here, except I do think you may have less people wanting to let their licenses lapse because of employment situations. I don't know if that would be a problem for you, but I know, like, for instance, for pharmacists, if they're not continuously licensed, they get terminated. So
I'm thinking
I
of
don't
people
know.
who have multiple state licenses, maybe that travel.
Okay.
And so, let me go to the licensing report here. Sarah's not even here to say anything about, but how many, let's see.
People are delinquent. I'm
My
not
eyes are too
sure.
old to read that. So, yeah, so delinquent
Would be the C.
is D, right? D. Is 1,835 licenses.
That's a lot
That
of
is a
money.
lot of money
That's
that
a
we're
lot.
gonna lose.
10% of our licensees.
10%, well, Actually, a little
Wow.
more than 10%, because we have 12,900.
If you look at the total number of licenses we have on all statuses, it's 18,425.
Oh, you're right. You're right. That's correct. Okay. So yeah, it is 10% of our licensees, and then they can stay in that status for up to 5 years.
Wow.
Yes.
And then at 5 years, they drop out of that status and they just
They
have to
cancel.
reapply.
Yeah.
So I think there's a protective mechanism there. If they don't want to pay the fees, let it expire and apply like new. You don't have to pay the back fees.
Right.
I would say we should oppose this because we're going to lose a lot of money. And there is an alternative mechanism. If they don't want to pay the fees, they can just
Right.
come back in 5 years and reapply.
I agree.
So I'll make that motion.
Okay.
Second.
Okay. Further discussion?
I have one question.
Sure.
I looked it up again yesterday. On 427, it's sent to consent calendar. So what does that mean?
427.
Sent to consent calendar?
Yeah, I looked it
Where'd
up
you-
again yesterday. and-
AB 544?
Yes.
It went to consent. I'm not sure. Mary's more expert on this,
Okay, I'm
what
just-
that means, and I'm sorry, I'm not as up to speed on legislative process, like where we are, but it's still moving, I know
Okay.
that much. So it hasn't, if it's put in the suspense file, there's a chance it won't go farther. But if you see that it's still moving through and there's a status update and it's within this last month, yes,
Doing pretty good.
you can assume it's still moving forward.
Okay.
Further discussion? Okay. Public comment? I'm getting better at that.
Thank you.
Yeah, no public comment. Okay, Julie, will you call the roll?
Charles Alexander,
Aye.
Juan Armenta,
Aye.
Jennifer Carlquist. Aye. Sonia Early,
Aye.
Javier Escobar Costa, Jed Grant,
Aye.
Xavier Martinez,
Aye.
Robert Sachs,
Aye.
Mary Valencia.
Okay, so the motion carries. We'll oppose AB 544 for the stated reasons.
Okay, AB 613, that's our regulatory fees and the professions and vocations. The status is that it's currently in assembly. It's scheduled for hearing on April 2nd in the Committee on Business and Professions. This bill would authorize programs within the Department of Consumer Affairs to increase their fees every 4 years in the amount not to exceed the increase in the Consumer Price Index in the last 4 years. So fees increased pursuant to this bill would be exempt from the Administrative Procedure Act.
So what does this mean for us?
So I like the idea that we wouldn't have to do a rulemaking, but every 4 years you could increase your fees according to the California Consumer Price Index, which is published every year. The only thing that I'm questioned about, and it's not clear to me here, although the legislative analysis says that you can still, if this is not enough to get you, for instance, out of the red, you can still do an APA rulemaking to go above the Consumer Price Index to increase a fee, because we're going to be doing that on the application fee. So this applies to every fee that you use, every fee. So delinquency, application, renewal, every fee. So it would be a nice way to continue to get revenue without having to go through the rulemaking process. But I just would like it to make clear that if this is not sufficient to meet operating needs, that you can still have the option to go through because this is notwithstanding any other law. Whenever it says that, that means no matter what everything else says, you can only increase your fee every 4 years to meet the consumer price. And I don't like that. That to me seems too restrictive, and maybe they didn't intend it that way, because like I said, the legislative analysis says that that you still have the option, but it doesn't say that in the text. So what I'd like it to say in the text is that notwithstanding A, you are still able to adopt a regulation in conformity with the APA if you need it for operational needs or able to demonstrate it.
So it
Something to
doesn't say that?
No, it doesn't.
Oh.
So that's why I'm like, what about if you need to increase it more than every 4 years because you're going into the red and maybe you got a very expensive litigation case with the Attorney General's office or something, or you have litigation expense, and you need to increase fees.
We'd still have our current process, but we could also use
Well, that's
this.
what I wanted to say, that you can
Okay.
still use the other process in addition to this one. So, like I said, I like the idea of the increase automatically with no regs. That's great, but can we just have a placeholder or clarification in the language that says, notwithstanding A, the Consumer Price Index authority to increase every 4 years if you need to do a regulation beyond that cap, or sooner than every 4 years, that you would still be authorized to use the Administrative Procedure Act. Do you see what I'm saying?
So a support if amended?
Yeah, that would be a possibility.
Support if amended?
Support if amended.
With the language, Christie, decide to include the ability to increase
Fees
Fees if
due to
needed.
operational needs.
operational needs via the Administrative Procedure Act? That's
Correct.
the amendment we want.
Yes.
So that's the motion. Anybody want to make it?
Second.
Okay, the motion to do that is by Mr. Sachs, seconded by Mr. Martinez. Further comment? Public comment? Okay, Julie, will you call the roll?
Charles Alexander,
Aye.
Juan Armenta,
Aye.
Jennifer Barquez. Aye. Sonia Early,
Aye.
Javier Escobar Costa, Jay Grant,
Aye.
Xavier Martinez,
Aye.
Robert Sachs,
Aye.
Mayor Williams.
All
The
right.
motion carries. So we will support if amended for AB 613.
AB 890, that's our nurse practitioners. It's currently in assembly and was re-referred to the Committee on Appropriations. This authorizes a nationally certified nurse practitioner, or NP, to provide specified medical services without physician supervision. If the NP, among other things, works in specified integrated or organized health setting, or the NP meets specified education requirements and completes a 3-year transition to practice program. So,
That was the bill before April 22nd. So April 22nd, there were major amendments to this bill. And what it did is it took out all that and it replaced it with the requirement that the nurse practitioner, if they want to have this advanced practice, kind of an independent type practice license, that they have to get licensed by a brand-new Advanced Practice Registered Nursing Board with a new examination and new 4,600-hour practice requirement and professional liability insurance. So they have to pass an objective exam, which hasn't been developed yet. They have to have professional liability insurance, and they have to meet transition to practice requirements developed by this new board, which doesn't exist yet. And they have to have 4,600 hours, 3 years or 46 hours in transition to practice. I'm not sure what that means. Maybe you do. But, so this is how for everybody, for my really education as well as maybe some of the public members. So this would be a model where you'd have to get an RN license, then you'd have to get a certification by a national certifying body. Then you would also have to get another license from this nursing board with all those requirements, pass an objective exam, professional liability insurance, and the 4,600 hours of transition to practice, and also proficiency, I don't know what that means, in competencies identified by this new board's regulations. I don't know what that, I have no idea. It's completely unknown to me. I've
so
never
how is
seen
that
anything like
different
that.
than what they have currently, I guess? Because they're
Well,
able to practice.
They would have to get 2 licenses, and they would have to get a certification from a national body. That doesn't exist right now.
Right, but what about the people who are already, the MPs that are already practicing? How is that
They
different?
could not, well, they are allowed to practice independently. That's the difference.
This is independent for,
This
if
is
they want to be
independent
independent, this
practice.
is what they have to do. Otherwise, they have to
They're
have a
supervisor
with
and
the
same-
protocols. and
Right,
Got it.
exactly.
Have to be like us.
So the nursing board, like the prior version, like some members did of the bill for physician assistants previously, and supported it, but they haven't seen this new one. And I guess they're meeting in June, so it'll be interesting to see what the Registered Nursing Board thinks of another board. And how would they even work together? What if they have the same licensee? How they would coordinate discipline, that would be kind of a messy process. So it'll be interesting to see whether this bill goes anywhere after this amendment.
Could I make a recommendation that
Sure.
that we just stay well clear of all this?
But these were, I guess,
I agree.
CMA amendments.
Right.
CMA amendments.
That sounds eerily familiar.
Mm-hmm.
Okay.
Watch.
All right. Staying clear? Is
Staying
that-
clear.
Okay.
Yep. All right, AB 1184. This is our public records retention. This is writing transmitted by electronic mail. This bill addresses, the status is in assembly. It passed Judiciary Committee, and it's referred to appropriations. Okay? So basically, we need to keep all of our emails for 2 years, but this bill addresses the question on how long public agencies must retain electronic writing or email. So the governmental code 34090 prohibits city departments from destroying public records that are less than 2 years old. So I don't know if we have the system to
I don't
keep
know
all
if we
that.
have the bandwidth to retain
Right.
it. We wouldn't be able to delete any emails,
Right,
ever,
For
for
two-
2 years.
2 years. Yeah.
Even out of office and things that are not really.
Right.
But I know there's a lot of people, what this is designed to address is every board and bureau in the department's allowed to develop a records retention schedule. And the department also has an electronic mail retention schedule. I think years ago, we were looking at a 2-year requirement. And then it never got resolved, I think, about how long we should be keeping it, because it's really based on litigation and other things. So the question is, what would be the fiscal impact of retaining every single email and the liability? Because, if we have a record retention schedule, for instance, I know the Attorney General's office has a 90-day retention schedule. And they do that because it is expensive, and also it's a liability to retain a lot of data. And I have been personally involved in a case where I had to review 1 million lines of data to produce because we kept it. And it was excruciatingly painful. I had to have a task force of attorneys working day and night to get through all of it to figure out what was privileged and what was disclosable pursuant to the litigation. We ended up settling the case. But that just taught me that we really need to have reasonable restrictions on how much data we collect, because it is really expensive to deal with litigation
Right.
when we have that much information to cull through. And so this would not allow us to set our own retention schedules for email. And we would have to be able to pay for the storage of all the emails. And it would probably come in the form of a departmental-wide contract where we would pay pro rata
Right.
to support and store it. So
Wow.
What is the purpose? Why do they want to do this?
I think I read in the legislative analysis that they feel like we inappropriately destroy records that are of public concern. And so just to set a bright line standard that everyone has to enforce, they cite this city department's requirement and think it would be a good rule to follow for all state agencies in the state.
Well, I think it's a terrible one. So what do you all think
Wow.
about opposing this? Just due to cost and workload burden.
Yeah. Well, I don't know how they would, cost effectively do that for every agency, every public agency.
Well, I mean, every agency should determine this for themselves, right?
Right.
Like, how much can we afford to store? What's our bandwidth?
Right.
We're on the MedBoard servers. How much can we store there? For how long could we do it? And if we suddenly have to do it for 2 years, does that mean we have to get an additional server, an additional IT
definitely.
person to track all this stuff?
yeah.
Like, for what
Probably a
purpose?
team.
So,
No,
I would vote to oppose it.
oppose.
okay, so motion to oppose due to cost and
Second.
is by Mr. Martinez, seconded by Ms. Early. Further discussion?
Well,
Public comment?
just that, until you sue the government, and figure out, nobody here, but some knuckleheads at some government agency to decide to do something crazy that you need to know about, that's when you want this stuff. I can't see it how it would apply here to us. It's not directed towards us. But there are city councils that decide, oh, well, so-and-so donated to my campaign and there's 3 of them that did, so we're going to give him his variance on his house. Well, I want to know that when the guy is building a 10-story house next to my single-story residence.
Okay.
So
So
for
you
us,
think
yeah,
it's-
I get it, but I believe in transparency in government, so.
Okay. So you think it's a mistake to oppose then?
I don't know how much weight our opposition is going to carry.
Probably not.
Yes. But yeah, just from that perspective of having to sue the government and give me the stuff is difficult often.
Well, they could we could oppose unless amended and say that it only applies to, it doesn't apply to boards and bureaus. No?
Yeah, I don't know.
Further comment? Okay. Public comment? Okay, Julie.
Charles Alexander,
Aye.
Juan Armenta,
No.
Jennifer Carlquist,
Abstain.
Sonia Early,
Hi.
Javier Escobar Costa, Jed Grant,
Aye.
Xavier Martinez,
Aye.
Robert Sachs,
Aye.
Mary Valencia.
Okay, motion carries.
Okay. AB 1819, public records, use of requester's own equipment. Basically, this bill merely clarifies that a member of the public has the right under the California Public Records Act to make a copy of a public record on the premise of the agency by using their own equipment without paying a fee. So I would probably.
Yeah, that's existing law. We cannot charge someone a fee if they bring their own copier. The only time we ever charge a fee is when they ask us to prepare the copies and mail them to them.
Right.
So
Just
I
watch.
don't see this as changing how we do business currently,
Right. All right, so we just watch it.
in case it changes, I guess.
Okay. Are we good? SB 53, Open Meetings Act. So this is passed out of the Senate over to the Assembly. After the first reading, it's held at desk. Okay. The bill will revise the Bagley-King Open Meeting Act regarding state body created advisory committees by requiring 2-member advisory committee to hold open and public meetings if one or more of the advisory committee members is a member of the larger board, committee, or commission. And the advisory committee is supported either wholly or partially by the state funds. So the purpose of this bill is to make the Bagley-King Act mirror provisions of the Ralph M. Brown Act, which governs local government's opening meetings. So that could pose a problem.
Yeah, we do a lot of.
We do a lot of 2-person advisory committee meetings
Right.
that are, because under current law, the only time you have to notice an advisory committee meeting is when it's 3 or more persons. And so there's multiple situations this board will use the 2-person advisory committee. And the reason why it's not required to be noticed is that they have to report back to the board. And the board has to discuss their findings in public and take action, so the public would have an opportunity to comment. So this would cover your current legislative committee, your education workforce development advisory committee, and your executive officer recruitment process, because you usually set 2 people to reviewing all the applications and then reporting back to the board. So those committees would be affected and would have to be formally noticed in order for you to hold them. Governor Brown vetoed in the last 2 years legislation that was similar to this, and his belief was that because of the fact that the advisory committees do report back to the public, that there wouldn't be a deprivation of the public's right to know and have transparency. I don't know how the current governor's going to view it, though, so that's probably why the bill's back for a 3rd time.
Okay. Do we want to watch or,
I think in the previous times this came through, we opposed,
yeah,
because we do a lot of our business
We
via
do.
those committees.
I would agree to oppose.
Okay? And do you want to attach a information that you want the staff to include why we're opposing?
You can, yes.
Which
What
is?
would you like it to say?
Well, a lot of our committees are two-person committees, and we need to make sure that we can get the business done without having a new open meetings.
Having to have a noticed meeting and that the two-person committees always report back in
Right.
public
Back to the board.
and don't have decision-making capacity, they just gather
Right.
information.
Other information.
Further comment?
So that was a motion.
Who made the motion?
Sonia?
I'll make the motion.
Sonia made the motion, and Jen, did you second?
I did.
Public comment? Okay. Julie?
Charles Alexander,
Aye.
Ron Armenta,
Aye.
Jennifer Carlquist,
Aye.
Sonia Arley,
Aye.
Javier Escobar-Costa, Jed Grant,
Aye.
Xavier Martinez,
Aye.
Ellen Stutz, Mary Bowser.
Okay.
All right, SB 425, that's our healthcare practitioners licensee file, probation physician and surgeon certificate of unprofessional conduct. So current status is that it's in the Senate, scheduled for hearing on April 8th in the Committee on Business, Professions, and Economic Development. And this bill would require to expand sexual abuse reporting requirements to the healing arts licensees and their employees. So, and that's key. So this could be up to a $50,000 to $100,000 fine if that takes place.
So this is a new reporting requirement. The bill was amended again recently, but the provisions relating to the requirement for reporting remain. And it says that an employee or a healing arts licensee that works in any health facility or clinic, healthcare service plan, or other entity applies to who has knowledge of any allegation of sexual abuse or sexual misconduct by a healing arts licensee shall file a report with the agency that has regulatory jurisdiction over the healing arts licensee and the administration of the health facility or clinic, healthcare service plan, or other entity within 15 days of knowing about the allegation of sexual abuse or sexual misconduct. So it's an allegation, and if you hear about it or have knowledge about it, you're required to report it, and you're required to report it to that person's licensing body within 15 days. And a willful failure can be fined by that agency, whoever it is. So, for instance, if you see or hear about a physician who has allegedly committed sexual abuse or sexual misconduct, you're required to report to the medical board, and a willful failure can be fined up to $100,000, and a negligent failure is up to $50,000 per violation.
That's hard to prove, though.
Yeah, and I mean, that's what CMA's opposition was. The CMA wrote, as currently written, this bill creates an enormous administrative burden on all healing arts licensees as well as their respective licensing boards by requiring every potential complaint, whether or not it is substantiated, actually spoken by the patient, or simply a rumor in a staff break room, to be reported to the licensing board of the licensee who is the subject of the complaint. Now, the author disputes that a rumor would qualify, but I do think it would probably need more clarification about what an allegation of sexual abuse would trigger the reporting requirement, because it's pretty significant liability. But it would give this board the ability to fine other people's licensees and other persons that aren't even licensed by you.
Wow.
Because it
Say
says,
that again, how does that work?
it says an employee that works at a health facility. So you could find some employee that's not even a licensee for not reporting if you find out during an investigation that they had knowledge of any allegation of sexual abuse or sexual misconduct by a healing arts board licensee. So if you look at subdivision C of section 2 of 805.8, which is being added to the section of the BNP code that applies to all healing arts boards. It's a pretty significant new authority that you would have, but it would certainly affect everyone that's a healing arts licensee: nurses, podiatrists, doctors, physicians, dentists, anyone that you come in contact with in your profession. And it would apply to an employee who's not even a licensee. They would have to report too. So that'd be a significant expansion of your authority to enforce sexual abuse or sexual misconduct violations if it was your licensee.
Yeah, but that just heard about it thing, you know, I can see someone being like, oh, P.A. Jones was rude to me, so I'm gonna start a rumor, and somebody else hears the rumor and is like, you know, I agree that it could be, and you're talking about a $50,000 fine. If you hear it from someone who heard it from someone, and you don't report it because you think it's just a rumor, and then you say, oh, well, if I don't report this,
Right.
you're facing a $50,000 fine or $100,000 fine. It's like,
So you could approach it like it'd be a difficult standard to enforce, and it may lead to duplication of investigation by multiple agencies. I mean, while you support, public protection, that it may be a little bit too ambiguous to implement. I mean, I don't know, you gotta be careful a little bit, I think, because it is a very emotionally charged issue, and it is a serious problem as we've seen in the last few years. It's become a big public policy issue.
I think it's
So-
much more of an issue for the medical board than it is really for us in looking at some of their cases and things that, are going on there. Maybe this is one we should watch.
Okay.
Boy, you think so? I mean, this is really draconian. I mean, it puts us in a position, so, the medical board too, of now being adjudicators of whether the initial rumor, accusation, whatever it is sufficiently valid to trigger the duty.
Right.
And then whether the duty failure to fulfill that duty is, what do they use here? Willful,
Willful or
voluntary, intentional
or
violation?
failure, because E says failure is up to 50,000, so it's negligent.
Well,
That
isn't
is-
this already duplicative because we're already mandatory reporters?
Yeah.
So,
Well,
But this is reporting on
staff.
other people.
This is
so
not-
you.
Yeah.
Sorry, go ahead.
No, I was just gonna say the same thing. This is staff in the clinic. This isn't licensed people reporting other licensed people, although it could be.
Yes.
But they're really talking about the staff in the clinic that becomes aware of it, that they could be
Yes.
disciplined
liable.
or fined.
Right.
Watch.
I'd like to put a motion to oppose on the basis that the standard is not sufficiently workable, and would be better left to law enforcement.
Oh, amen, I agree with you.
Well, the other thing is that we already have systems in place at the hospital level that they're supposed to report to, whether they're, employee, faculty. So I think, again, it's duplicative.
I mean,
But I
you could
understand.
do a watch, but issue a letter of concern. That's another option.
I just have concern about irritating the author.
Okay.
Who's the
Senator
author?
Hill's the head, is Senate BNP.
Yeah.
Oh, I see.
Yeah. So, I
By
like
taking
that's an elegant solution, a watch, but send a letter saying what some concerns
Concern
are.
about the ambiguity and the real possible unintended consequence of assessing people based on an ambiguous standard that, might cause serious litigation and enforcement problems for the board.
Yeah. Or almost encourages, it creates this,
It's such an ambiguous
Right,
standard.
so ambiguous that people
anyone
are
could
get-
report anything
Right, and
all
then
the
you
time,
have
and then you have a lot of potentially
investigative
unfounded
costs.
complaints that you're
Yes.
investigating, and then the ones that are founded would get ignored.
yes. Generate a lot of false leads because it's not specific enough.
Right.
So,
I'll withdraw my prior motion in light of Jed's comments. You can make, so a new motion would be send a letter of
I
concern.
was going to ask if you wanted a second, but since you withdrew, yeah. So the new motion would be to take a watch position and send a letter of concern to the author, expressing those things that we discussed.
I'll second that.
I guess I'll make the first. Further discussion? Public comment? Okay. Roll call.
Charles Alexander,
Aye.
Juan Armenta,
Aye.
Jennifer Carlquist. Aye. Sonia Early,
Aye.
Javier Escobar Costa, Jed Grant,
Aye.
Adrian Martinez,
Aye.
Robert Sachs, Mary Williamson.
Okay, so motion carries.
All right, SB 518, that is our court costs and attorney's fees, public records disclosure. That's currently in the Senate Appropriations Committee awaiting hearing date. And that is the California Public Records Act requires a public agency defined to mean a state or local agency to make its public records available to the public for public inspection and to make copies available upon request and payment of fee unless the public records are exempt from disclosure. The Act makes it specified records exempt from disclosure and provides that disclosure by the state or local agency of the public record that is otherwise exempt and waivers of the exemption. So this could be a costly or cost in litigation. So.
Yeah, so Mr. Arment is probably real familiar with the Code of Civil Procedure 998 offer process.
Right.
So this bill seeks to prevent state agencies from using the 998 offer process. And so what that is under Section 998C of the Code of Civil Procedure, if you make an offer to someone who's suing you in PRA litigation and they fail to obtain a more favorable judgment, then they lose the right to get attorney's fees and costs. And sometimes they have to pay yours, depending on how much, what the offer looks like. So this would prevent us from using that litigation tool against people who bring Public Records Act claims if they win. Doesn't matter if they win more than what you offer. Like, let's pretend you offered them $10,000 and they got $1. They would still be able to get all their attorney's fees and costs because they prevailed. Do you see what I mean?
Wow.
But in current law, if they only got $1, they wouldn't get attorney's fees and costs, and they have to pay their own attorney's fees costs. And so this bill seeks to essentially prevent the state from using that litigation tool to save it money, that other private parties could still use it. So I don't know whether it's worth it for you since you don't have too many Public Records Act requests, but it would just be something you would have to be aware of going forward. If you're in PRA litigation, you know, you could still lose even if you win, so to speak, if this goes into effect.
Watch.
Okay. No action?
Okay.
All right.
Is that correct, Sonia? You wanted to
I
take
think
no?
a watch.
Well, okay.
You guys want to, how about you guys? Do you want to?
Yeah. Does anyone want to suggest a position, or we just move on?
Okay.
That's fine.
Okay.
Just watch it sounds.
Okay.
Okay. SB 615, this is the public records disclosure that's currently in the Senate Committee on Judiciary awaiting a hearing date. So this is a bill that require the California Public Records Act requires the public agency, defined to mean the state or local agency, to make its public records available to the public inspection and to make copies available upon request and payment of the fee unless the public records are exempt from disclosure. And the bill basically will require a person to meet and confer in good faith with the agency in the attempt to informally resolve each issue before instituting any proceeding or injunctive or declarative relief or writ of mandate. So.
Yeah, I mean, I like it. I like the fact that they would have to meet and confer with us before they sue. That would be great. I don't know how far this will go, but the concept, I think, is to our advantage, certainly, if there's some way for us to informally resolve, and we do try to do that, honestly.
Right, we do.
If people are unhappy with the answer they get. But it's nice to have it in law that they can't just go running to court and sue, that they have to they have to prove that they tried to resolve it with us before they sue. I mean, I like it, but again, I don't know
Bless you.
where it will go.
Okay, so just watch.
Yeah, because we don't
Yeah.
have, again, we don't have that many Public
Yeah.
Records Act, so.
Right.
Yeah.
Not too many.
All right. And last but not least, guys, SB 1109 is the controlled substance Schedule 2 drugs on opioids. The status is that it was enacted. The bill passed last session and was adopted. But just to remind you guys, this bill, one, amends the existing mandatory continuing education course content requirements for physician assistants and surgeons and nurse midwives, nurse practitioners, dentists, DOs, and optometrists.
Yeah. So it didn't really change anything for this board because your board already requires the course to include an analysis of the risks of addiction. So it didn't change anything for you. I think at the time when we asked for this to be on the agenda, we were thinking there was going to be more in this bill, and it didn't end up being that way. In March, it was just the content of the course.
All right, so that is it. Thank you, guys.
All right, yeah, nice work, Sonia. Kind of got it at the last minute there. The last thing on the agenda is the agenda for the next meeting. Well, we probably ought to do both meetings, right? Because we have to post an agenda for the next meeting in May. So on the agenda for the meeting in May, it will be SB 697. Anybody else have anything else they want to put on that agenda?
We may have some regulation proposals to bring to your attention. One has to do with renewal of licensure, and the other one may be, it just depends on my workload, the discussion we had earlier on auditing course providers for continuing education for the continuing medical controlled substances course.
Okay.
So
controlled substances course legislation update
right.
and other legislation update, our regulation update, right? So that would, yep. Anything else we want on the May agenda? Okay, moving on. Anyone else? Anybody from the public want anything on the agenda? Okay. Moving on to the August meeting.
So I was thinking that was for August, sorry.
Oh, okay.
So I think we were just gonna do this SB 697 in May.
Okay.
Yeah, because possibly it's gonna be teleconference plus live.
Yeah.
Right.
So, yeah, no.
So, okay, so we'll modify that. So the May meeting, just SB 697. With the other listed items that Christie talked about for August. Let's see, I don't think the Education and Workforce Committee will have an update. Does the Budget Subcommittee have an no? Okay, just want to include you. Do you, I guess we can just add those as needed. For right now, did we bring up anything else that needed to be on a future agenda? Okay.
What about any, like your legislative proposal for the fee increase? Do we need an update on that, or?
We will.
Okay.
Okay. Probably need an update on all of our pending legislation.
Correct, that you've taken positions on
Yep.
and watched.
Well, and our own regulation updates as well.
Right.
I think, unless anyone else has anything, I think that's probably it.
Okay.
Okay, great.
Move to adjourn.
Motion to adjourn? Okay. Do we have to vote on that? Or
Yes.
Okay. Further discussion? Public comment. Julie, call the roll for the motion to adjourn, please.
Charles Alexander,
Aye.
Juan Armenta,
Aye.
Jennifer Carlquist,
Aye.
Sonia Early,
Aye.
Javier Escobar Costa, Ted Grant,
Aye.
Xavier Martinez,
Aye.
Robert Sachs, Mary Valencia.
Okay, motion carries. This meeting of the PA Board is adjourned. It's a record meeting.